slides. So according to the International Agency for Research on Cancer, gastrointestinal cancer accounts for about 1 in 4 cancer cases and 1 in 3 deaths all over the world. The incidence of GI cancer worldwide in 2022 was 4.8 million, and the mortality was about 3.4 million. There is considerable variations in incidence and mortality across the world. The gastric cancer incidence has decreased over time, and colorectal cancer incidence has increased over time in some low incidence areas. Liver cancer and pancreatic cancer, on the contrary, the incidence has increased in high income countries. And there is considerable variation in practice in managing GI cancer across the world. Hello and a warm welcome to everyone who has joined us online today, as well as offline, in our international hybrid CME on GI cancer, controversies to consensus. My name is Dr. Animesh Saha. I am a senior consultant clinical oncologist working in Apollo Multispecialty Hospital, Kolkata since 2019. And prior to that, I have worked as a consultant in Leeds Cancer Center, UK. In next 4 hours or so, we are going to witness renowned experts in the field of GI oncology about their experience, views on the management of GI cancer. They're going to join hands together from not only India, but also from United Kingdom, Bangladesh, Nepal. Faculties are going to join hands together to sort the controversies out and come to a consensus. We're quite excited to know that we have 180 odd online registration from 9 different countries, including India, United Kingdom, United States, Bangladesh, Nepal, Singapore, Brunei, Cambodia, Papua New Guinea, and we are expecting about 70 odd offline registration also. Before we start our academic session, may I request our guest of honors to come over to the stage. Our respected DMS sir, Dr. Surinder Singh Bhatia, Dr. P.N. Mohapatra sir, Director of Department of Medical Oncology, our MS sir, Dr. Parth Bhattacharya sir, Dr. Mohesh Goenka sir couldn't attend because of some personal commitment. So also Dr. Abhijit Majumdar and our CEO sir. May I request Dr. Tanmoy Mukhopadhyay, our organizing chairman, to also join the dais. I request our organizing chairman to give a brief introduction about our program. Please come over to the dais.
Good afternoon, everyone. I would like to thank everyone who has joined in this meeting, both from India and abroad, online and offline. I just would like to talk about a few words about this whole concept of hybrid kind of academic meeting. Dr. Animesh has taken initiative and he has worked very hard to organize this meeting with all his team members. And when he came to me to discuss about this, then we thought that we would not compromise with the quality of the academics. So otherwise, you know that with the physical meeting in a large hotel, a lot of budgets and money are required. So, but we did not want to compromise with the quality of the academics. And as you have already heard, that we have faculties from India, from United Kingdom, from Bangladesh, and from Nepal. And we have participants from 9 countries of the world, and which include United Kingdom, United States, and also African countries and our neighboring countries. So we have very distinguished speakers. and who will be delivering on their specialized field, which is the GI cancer. And I have no doubt in my mind that you will be greatly benefited from attending these meetings, both kind of consultants and doctors, and also postgraduate trainees. So again, I won't take much time. I would like to thank everyone again, and I hope that this is going to be a very successful meeting. Thank you.
Thank you, Dr. Mukhopadhyay. May I request our beloved Dr. Surinder Singh Bhatia, sir, our DMS, sir, to give a brief introduction.
Thank you, Dr. Animesh. I think it is a very momentous occasion that conference of this hybrid nature on a very contemporary topic has been chosen, and will the participants and the faculty from India and abroad. We are proud and privileged to have a team of excellent and outstanding consultants with us at Apollo Multi-Speciality Hospital. I was just going through the program also, and I think the topics like which are the neuroendocrine tumor carcinoids, new diagnostics. We have recently acquired the gallium synthesis equipment. So I think with the new polypeptides which will be there, our consultants will have a much better armamentarium to take care with the iodine therapy ward which has come in. And I think it is very good that we have under one roof here, including options like TACE, which will be also discussed. Thank you very much. I think we look forward to a very exciting CME on this count. Thank you. Thank all the those who have taken part to hold this conference besides Dr. Animesh. Thank you.
Thank you very much, sir. May I request Dr. P.N. Mohapatra, sir, Director, Department of Medical Oncology, to come over and have a brief introduction about this program. Over to you.
Thank you, Dr. Animesh and Dr. Tanmoy, for organizing such a beautiful conference. Actually, COVID taught us to be online conference, and now post-COVID, some physical conference. So it'd be very difficult actually to get such a good faculty from outside and have a physical conference. Visa issues, COVID issues, a lot of issues are there. But I think the topics chosen are the best, and actually it's not very common to be discussed in any meeting. So we have meetings which is same thing discussed repeatedly, but these topics are very good and very excellent speakers actually. And if you go to their biodata, they're excellent speakers. So I wish this conference will be best to acquire the required knowledge, which is not in a common subjects, uncommon subjects. And I thank again Dr. Animesh and Dr. Tanmoy.
Thank you. Thank you very much, sir. May I request our guest of honors to come forward for lamp lighting and inauguration of the program. Can we have? May I request Dr. Kingshuk Das, sir, to also join the lamp lighting. Also, Dr. Ellen Biswas, sir, and Dr. Arunabh Sengupta, sir. Dr. Shubhrata Saha, sir, Vikas, sir, please join us. Dr. Prosenjit, sir, please. Shubhadeep, Sheila ma'am. May I have some round of applause? Thank you very much. Before we close this session, may I request our organizing chairman, Dr. Tanmoy Mukhopadhyay, sir, to hand over the memento as a token of appreciation to our guest of honors. DMS sir, please come over. Partho sir has left. Dr. PN Mohapatra sir. Can we call Partho sir? Thank you. I think Partho sir has left. Okay, so we'll now sort out the logistics. Arindam, can we move the chairs out and on the screen, switch on the screen of Zoom meeting? And can we ask the lamp light, lamp standing to be removed? We need to move the chairs as well as the lamp. And can you move back to the Zoom meeting? Just a couple of minutes to sort out the logistics. Okay. So next we'll be moving on to our first academic session. And may I request Dr. PN Mohapatra sir to stay back on the chair and to chair the session. So Dr. Mohesh Goenka sir couldn't come over because of some unavoidable circumstances. Yeah. So please join, sir. Please join. So we all know that surgery is the mainstay of treatment in localized pancreatic cancer. However, as an oncologist, we now understand that neoadjuvant and adjuvant therapy plays a very important role in the management of localized pancreatic cancer, not only for the downstaging, but also for reducing the risk of recurrence, as well as improving the survival outcomes. Our first speaker, Professor Jonathan Wadsley, is going to speak about this very important topic. He has been one of my mentor while I was working in UK and helped me a lot when I was in early stages of my career. May I request Dr. PN Mohapatra sir to introduce our first speaker and start the session.
Thank you, Dr. Animesh. And actually, Dr. Jonathan Wadsley, it would have been best if he would have been come and with us, but he is a clinical oncologist, Western Park Hospital, Sheffield, UK. His areas of interest is thyroid cancer, neuroendocrine tumors, pancreatic biliary tumors, and molecular radiotherapy. He is currently the clinical director of the Sheffield Clinical Trial Center, Cancer Clinical Trial Center, Cancer Facility Lead for the Yorkshire and Humber Clinical Research Network, and a Nations Facility Lead of Radiotherapy and Imaging of the UK. Sir will be speaking in the recent advance in neo-adjuvant adjuvant treatment. Actually, pancreatic cancer, it's not like when going for surgery in all patients. You have to discuss with the surgeon and the radiation oncologist. It is a more of a trimodality treatment nowadays. So how we will go for the trimodality treatment, and Dr. Jonathan will be speaking about that. Sir, please.
Rahul, can we have him on screen? Can we have Professor Wadsley's slide on the screen, please?
Great, thank you. Can you hear me?
Yes, John.
Great.
Hear you.
Great. I'll make a start then. So thank you very much for your really kind introduction and invitation to speak at the meeting. I have to say, having just looked at the weather forecast in Kolkata, I rather wish I was with you in person. It's rather drab and cold and grey in Sheffield this morning. But anyway, it's a pleasure to be with you and thank you for the invitation. So if we can move to the next slide, please. So just to give a brief overview of what I'm hoping to cover in the next half an hour, we'll start by just having a little bit of a look at the background to the problem of treating pancreatic cancer. We'll then move on to look at the evidence behind adjuvant therapies, and then some emerging evidence regarding the benefits of neoadjuvant therapy, particularly for operable and borderline operable disease. We will think about locally advanced disease. I've said neoadjuvant therapy in inverted commas here, because to me, neoadjuvant therapy is a treatment that we give for disease that is operable, and clearly locally advanced disease isn't operable. So in the strictest sense, this is, I think, downstaging treatment rather than neoadjuvant therapy, but nonetheless, I think there's a role, and we'll briefly touch on that. We'll then look at the role of some of the more exciting new developments in the treatment of pancreatic cancer and how they may fit in, and then just draw us all together with a summary. Next slide, please. So I'm sure you're all very familiar with the problem that we're facing. So the International Agency for Research on Cancer reported in 2020 that there are nearly 500,000 new cases of pancreatic cancer globally. And as we know, sadly, the vast majority of those patients will die of their cancer. In the UK, pancreatic cancer is the 11th most common cancer by incidence, but it's the 5th most common cause of cancer death because it is so lethal. And sadly, it has the lowest survival rate of all the common cancers, with a 1-year survival rate of just 24% and a 5-year survival of well under 10%. And the graph here just shows the trend in 5-year survival of various different common cancers in the UK. You'll see over the last 50 years, for most cancers, there's been a steadily improving trend in survival. Pancreatic cancer is represented by the purple line at the bottom, which you'll see is disappointingly very flat and shows really very little progress. Next slide, please. So clearly the stage at diagnosis of the cancer is absolutely critical to the most appropriate treatment. And what we know is that unfortunately over half of patients with pancreatic cancer do present with metastatic disease and therefore are inevitably going to be incurable. And there are many efforts to try and address earlier diagnosis of pancreatic cancer, although for all the reasons we know, that's very challenging. But even of the patients who have localized disease, only a very small minority, so around 8%, actually undergo surgical resection. And we know we can categorize patients with localized disease into 3 broad categories: those who are operable, those who are borderline operable, and those who are locally advanced. Can I have the next slide, please? So the degree of whether or not a tumour is resectable is decided really on the radiological appearances at initial staging, and particularly of the relation of the tumour to major vessels, particularly the superior mesenteric artery and vein and the portal vein. And if the tumour is too intimately involved with those vessels, sadly that renders the tumour inoperable. And the next slide, please. So there are various criteria defining resectability, but probably the most widely used are the NCCN guidelines from the States that I've put up here. And you'll see really the resectability status is decided on relation to arteries and veins locally. So resectable disease doesn't have any contact with the major arteries and has only minimal contact with the veins without any irregularity of the contour of the vein. Then this borderline resectable category that I think is very interesting, we'll be focusing on a bit later. So there may be contact with arteries and contact with the veins, but there are quite strict criteria about the degree of contact that can be had. And then the category of locally advanced disease, this is really where arteries and veins are pretty much encased by the tumour, and clearly there is no way that surgery is going to be successful. Next slide, please. Great. So starting by thinking about adjuvant therapy, so there have been a series of phase 3 randomized trials over the last 20 years or so that have demonstrated a definite survival advantage for post-operative systemic chemotherapy. There are challenges with this though. So most of these trials had in their inclusion criteria that the treatment had to start within 12 weeks of surgery. And we know, unfortunately, a significant proportion of patients are just not well enough to start systemic therapy within that time after major pancreatic surgery. The studies have also generally included both patients who had both R0 and R1 resection, so a proportion of these patients will have had microscopically involved margins, although generally they excluded patients with macroscopic residual disease. Next slide, please. So the first of these studies, and I should say the focus of my talk is going to be from a very European perspective, and particularly focusing on the work of the European Study Group for Pancreatic Cancer, who've been responsible for many of these trials. So the first of these trials, which was published in 2004, the SPAC1 trial, was really looking at two different approaches and was a 2x2 factorial design. So the first question was, could adjuvant chemotherapy, so specifically with a combination of 5-FU and folinic acid. So this was the very old-fashioned Mayo regime that was used in colorectal cancer for many years, of bolus 5-FU daily for 5 days, 1 week out of every 4. The other intervention that was being tested was chemo-radiotherapy, and it's slightly unusual and not a regime that we would use in this day and age, I don't think, but using 20 gray and 10 fractions with concomitant 5-FU. So to cut to the chase, what this study found was that there was a significant survival improvement for chemotherapy. 5-year survival improved from 8 to 21%. So that was really very impressive and very significant. Interestingly, for the chemo-radiotherapy, that actually showed a detrimental effect. So the patients who had chemo-radiotherapy had worse outcomes compared with the patients that didn't have chemo-radiotherapy. And this was really very significant for the role of chemoradiotherapy in pancreatic cancer in Europe, and really put paid to us using this treatment at all for many years. And that's changing now. But this study, I think, was very instrumental really in making us not use that treatment for many years. Next slide, please. Can we have the next slide? Great, thank you. So the next study in the series was the SPAC3 study published in 2010. And this looked at the more modern drug gemcitabine, which by that stage had moved into routine practice for advanced disease in pancreatic cancer, and compared gemcitabine with the previous standard of 5-FU and folinic acid. So what the study found was that the survival curves actually were overlapping for the two groups, confirming a very similar sort of survival to the chemotherapy group from SPAC1. But what was notable was that the toxicities were rather different. So we know with 5-FU and folinic acid, there are really quite high rates of high-grade stomatitis and diarrhea that were really very unpleasant for patients. and that was much less of an issue with gemcitabine. The problem with gemcitabine, one of the problems particularly was a higher rate of thrombocytopenia, but actually that very rarely caused symptomatic problems for patients. So in general, it was concluded that gemcitabine was better tolerated. And I think the result of this trial was that many centres moved to using gemcitabine as their standard in this situation. Next slide, please. So we then moved on to the SPAC4 trial, which was the first study to look at the role of combination chemotherapy in this setting. So comparing gemcitabine alone with a combination of gemcitabine and fluoropyrimidine. So this was a large study which showed that the combination treatment was actually superior. So the 5-year survival improved a little further from 16 months in the single agent group up to 28.8 months in the combination group. Next slide, please. Now, there was some interesting work that came out of this study looking at patterns of recurrence in pancreatic cancer. What we found in SPAC4 was that actually 90% of distant recurrences occur within 2 years of surgery. And in fact, half of liver metastases develop within a year. So those things suggest that this is disease that was probably there at the time of operation in terms of micrometastatic disease. Interestingly, there was no difference in the time to recurrence between either local or distant recurrences. And once you got a recurrence, there was no difference in post-recurrent survival, whether you had a local or distant recurrence. So all of this put together suggests very much that pancreatic cancer really is a systemic disease, and systemic therapy is really important. And we perhaps need to get on with that at an earlier stage in the treatment than we do at the moment. Next slide, please. So the final adjuvant study to report then, the most recent, was the FOLFIRINOX study. So this was a study run by the French group, published in 2018. So another large study looking at patients with very similar inclusion criteria, comparing the then standard of gemcitabine with modified FOLFIRINOX. Now, I think it's important to say it was inevitably a very selected group of patients, because only the fittest patients were going to be fit enough to cope with this very intensive combination regime. But the results are really impressive. The 3-year overall survival rate improved from 48 months with gemcitabine to 48% with gemcitabine to 63% with the combination regime. Now, I think just looking at the median survivals here indicates that this was a really very highly selected group, because we can see that the median survival of the gemcitabine group was much better than in the SPAC 3 or 4 studies. So I think this data needs to be, clearly there's an advantage for these selected patients, but this is not applicable to all of our patients with pancreatic cancer. Next slide, please. So clearly there are significant problems. Although there are advantages, there are problems to adjuvant therapy. As I've said before, many patients are not fit enough to receive treatment within 12 weeks of pancreatic surgery. We know probably only about 45% of all patients who've had pancreatic surgery get this treatment. And even the best results are really not great. So a 3-year survival rate of 63%, we could do better. And we know there's a very high R1 resection rate still, and that's known to be a very poor prognostic factor. Next slide, please. So neoadjuvant therapy, there are some clear advantages. There's an opportunity to get systemic therapy into the patient before they're debilitated by their surgery. We might earlier treat micrometastatic disease. There's a hope that we might reduce the R1 resection rate by shrinking disease before surgery. And we can assess the response to systemic therapy. There's something there that we can measure and see whether there's been a response. It may also allow better selection of patients for surgery. So we know some patients will progress through neoadjuvant treatment, but actually probably they're the patients with poor prognosis disease who are unlikely to benefit from surgery anyway. There are, however, challenges. Before embarking on neoadjuvant therapy, we need to get a histological diagnosis, and that can be challenging. There's concern about the potential to progress and become inoperable, although I think probably we might agree that those patients who progress through this treatment probably have very poor prognosis disease and weren't going to benefit from surgery anyway. And another concern is that actually compared with other solid tumours, the rates of response to systemic therapy in pancreatic cancer are not that great, and maybe this isn't a great group to use neoadjuvant therapy. So there are some concerns. Next slide, please. So I would like to share with you the results of the SPAC5 studies. This is the latest study to be published by the SPAC group, looking specifically at the role of neoadjuvant therapies in borderline operable cancers. And this was published recently in Lancet Gastroenterology. Next slide, please. So this is a multi-center study. It was really a feasibility trial run in 16 centers across the UK and Germany, looking at patients with borderline resectable pancreatic cancer by NCCN criteria that we looked at earlier. And the patients all had to have histologically or cytologically confirmed pancreatic cancer. They had to be good performance status. And there were 4 groups that patients were randomized to. So either immediate surgery, neoadjuvant gemcitabine with capecitabine, neoadjuvant modified FOLFIRINOX, or a neoadjuvant capecitabine-based chemotherapy radiotherapy regime. Next slide, please. So the patients had their treatment if they were having neoadjuvant treatment, and then had a restaging scan 4 to 6 weeks after treatment. If they hadn't progressed through that treatment, they then went on to surgical exploration within 2 weeks. Adjuvant chemotherapy was allowed post-operatively by investigator choice. I think it's important to say there was a lot of QA went into running this trial to make sure the results were reliable. So before going into the study, all the imaging was reviewed centrally to confirm that this was borderline operable disease. There was a lot of surgical QA, so there were surgical workshops run before the study set up, and then photographs were taken intraoperatively to confirm that the protocol was being followed. With the radiotherapy, there was quite strict QA run by the UK RTT QA group. So again, the radiotherapy plans were centrally reviewed before patients were treated. And there was also central review of the pathology, both the diagnostic biopsies and the resection specimens. Next slide, please. So just to give you an idea of how the trial panned out, so there were 478 patients screened for the study. Of those, only 158 actually consented to take part and were centrally reviewed. And of those, actually 68 were determined not to be borderline operable on review. So 90 patients proceeded to be randomized in the study. Next slide, please. So the primary outcome for the study, remembering that this was a feasibility study, the primary outcome was actually recruitment rate, and also looking at resection rate, seeing whether we could detect a difference between R0 and R1 resections. But there was also a series of really important secondary outcomes, including overall survival. Next slide, please. So the study ran over a 4-year period. As we said, of all the patients screened, actually only 90 were randomized. They were followed up for a median of a year. And there were 86 patients who had full data to be included in the full analysis set. So in terms of the number who underwent resection, so in the end, only about 60% of all the patients underwent resection. And there was no statistically significant difference between the 2 groups. And we know this fits with what we know about borderline resectable disease, that a proportion of these patients will be found to be unresectable when laparotomy. In terms of the R0 resection rate, again, interestingly, there was no significant difference between the 2 groups, the immediate surgery or the pooled neoadjuvant therapy group. So no significantly difference, statistically significant difference identified there. Next slide, please. In terms of surgical complications, which was a bit of a concern for the neoadjuvant group, so we know surgical complications are relatively common with this major surgery, but actually there was no statistically significant difference in complication rates between the immediate surgery group or the pooled neoadjuvant therapy group. There were no deaths within 30 days of treatment at all. There were 5 deaths within 90 days of surgery, but actually all of these were patients who were unresectable at the time of surgery and almost certainly died of their disease rather than of surgical complications. Next slide, please. So the really interesting result from this study was looking at the overall survival rates for each of the groups. And if we look first of all at the lower graph here, which compares the overall survival, comparing the immediate surgery group, the darker line at the bottom, with the pooled neoadjuvant therapy group, the red line at the top, you can see there's a really significant difference in overall survival. So even though the study wasn't actually powered for overall survival, we were able to detect a statistically significant difference and a real advantage for giving neoadjuvant therapy to this group. Looking at the top graph, this splits out by a neoadjuvant therapy group. And although the numbers in each group are small and this is not statistically significant, we can see that the biggest advantage seemed to be for FOLFIRINOX, the next best advantage for gemcitabine, capecitabine, and although there was an advantage for neoadjuvant chemoradiotherapy, that seemed to have the smallest impact. Next slide, please. So the conclusions from the study are that neoadjuvant therapies are deliverable with acceptable toxicity and no increase in perioperative complications. There does seem to be a significant survival advantage to neoadjuvant therapy when compared with immediate surgery, but this isn't interestingly related to any improvement in the R0 resection rate. And again, this does support the concept that pancreatic cancer is a systemic disease that we need to get systemic therapy into early. The other interesting finding was that the grade 3 and grade 4 toxicity rates reported for the chemotherapy arms seem to be less than those reported in the adjuvant studies, suggesting that these treatments are better tolerated in patients before they have their surgery than afterwards. Next slide, please. So there are some other studies in this area, and just to highlight one of the run by a Dutch group, the PREOP-PANC-1 study. So this was a smaller but phase 3 study, including operable and borderline operable patients, so that both groups were included in this study. The neoadjuvant component was gemcitabine based, but included both gemcitabine and chemoradiotherapy, and the control arm was surgery with adjuvant gemcitabine. So the study did show a survival advantage for neoadjuvant therapy, but that was predominantly seen in the borderline operable disease group with a statistically significant hazard ratio, as you can see here. Next slide, please. So the Dutch group have actually undertaken a meta-analysis of all the randomized controlled trials that have been undertaken of neoadjuvant therapy. Oh, I've lost the slides. Can I have the slides back? So I can't see my slides anymore.
Kashish, Rahul, can we have the slides of Professor Wadsley?
Yes, sir.
Go back to the last slide where he was there. Yeah.
Great, thank you.
I think it was before that.
Can we just go back a few?
Before that.
Back a few more. Yeah, that's the one thing. No, that's the one. Great, thank you. So the meta-analysis included 7 trials had nearly 1,000 patients in total. They all involved gemcitabine-based chemotherapy with or without radiotherapy. So none of these studies included the more modern regime, the FOLFIRINOX. What the meta-analysis found was that overall neoadjuvant therapy did improve overall survival, but looking at the subgroup of patients with resectable disease, there was no statistically significant difference found, although there was a trend towards an improvement. But where the significant benefit seemed to lie was with borderline resectable disease, where there was a significant improvement in the hazard ratio. Next slide, please. So just a touch on locally advanced disease. These are the NCCN guidelines, and I think the evidence base is not great probably in this area, and you'll see for fit patients there's a range of options recommended here, but some sort of induction treatment. In our practice we would use chemotherapy to start with, but often then add chemoradiotherapy to that, or hypofractionated radiotherapy, SABR type treatments. Then there definitely is a role for those patients who don't have disease progression or have response to reconsider surgery. But we know realistically the proportion of patients with locally advanced disease who actually get as far as surgery is relatively small with the treatments that we have available to us at the moment. Next slide, please. So in terms of new developments, there are some exciting new directions in pancreatic cancer we're aware of. So looking at precision oncology and looking at the molecular genetics of cancers, we know there are a proportion of patients who do have targetable mutations, and perhaps one of those groups is those with the BRCA PALB2 mutations who might benefit from PARP inhibitors. Maybe there's a role for those treatments in that particular subgroup of patients in terms of neoadjuvant therapy. Clearly, there's a lot of interest in pancreatic SABR and the evolution of MR-Linacs, allowing much better targeted radiotherapy for pancreatic cancer. And although the role of radiotherapy has been a little bit disappointing in neoadjuvant therapies to date, maybe if we can target and give higher doses of radiotherapy to the pancreas, that may well have more of a role as we move forward. And also there's been investigation into novel radiosensitizers, which may improve the efficacy of radiotherapy. The UK trial that we've run has investigated the role of nelfinavir as a radiosensitizer. Disappointingly, that study was negative, but there may be other ways of enhancing the effect of radiotherapy to see better responses there. So I think many more avenues to explore in improving treatment for this group of patients. Next slide, please. So just to round up with some take-home messages, I think the data that I've shown suggests that pancreatic adenocarcinoma is a systemic disease and does require multimodality therapy. Serial studies have demonstrated survival advantage to adjuvant chemotherapy, but there is now, I think, very compelling evidence that neoadjuvant chemotherapy is advantageous, particularly for patients with borderline operable disease. The situation at the moment is less clear for those patients who have upfront operable disease. I think further investigation is required there. And more research is needed to determine how these new developments are going to be best incorporated into our treatment protocols to improve outcomes for our patients. So thank you very much again. I'm very happy to take any questions.
Thank you, Dr. Jonathan. It's excellent deliberation, such a crisp on such a devastating disease in that way, and a huge subject. We really thank you, sir, for learning so much from you. And I think absolutely the right talk is that it requires a multimodality therapy. And we open, Dr. Animesh, we open the discussion. I think someone should have a look at the chat box.
Yeah,
and,
I think,
and they see the questions there.
yeah, I think we've got 5 minutes for some questions. We'll open the chat box. Those who are participating online can type their question in the chat box, and those who are participating online can ask question as well. So can I ask Dr. Sujan to hand over the mic to Dr. Professor Ellen Viswas, sir? I think he has got a question.
I have a question regarding adjuvant therapy in operable pancreatic cancer. As you said, the results were definitely positive, but is there any subgroup analysis of R0 and R1 cases? Because the series of studies, all they included both groups, R0 and R1. So I am concerned, is it that because of a high incidence of, what is the incidence of R0 cases in those groups? So maybe because of high incidence of R0 cases, the results were more towards. So is there any subgroup analysis?
So yeah, so we know those patients with R1 receptions definitely have a worse prognosis, but they do still benefit from. So there's still a survival advantage to them receiving the treatment. I guess arguably the treatment is probably palliative rather than strictly adjuvant in that group, because we know the outcomes are so poor. But there definitely is a survival advantage to having the treatment still, but it's not, those patients do worse than the patients who've had R0 resections.
Dr. Allen, you want to pass some comment? Dr. Anthony? Dr. Anthony?
Yes.
You want to ask, sir, please go ahead.
I hope it's okay for the faculty to ask questions. So John, we in Leeds do exactly the same as Professor Wadsley do in Sheffield, but quite often after the radiotherapy, very quickly after the radiotherapy, when we do other scans, there seems to be local progression of the disease. And looking at the literature, it sometimes, to me, makes me feel, do we really understand fully what we're expecting to see after giving radiotherapy to a locally advanced pancreatic tumor? And could that be stopping us operating on patients who might otherwise benefit? And in addition, I don't know if you want to just mention the PET Panc study, but a lot of the older studies we didn't, as Professor Wadsley was saying, in terms of occult metastatic disease, do we need to be better at selecting patients before putting them through neoadjuvant treatment?
Yeah, thank you, Al. I think really good points. And I think the whole problem of assessing patients after neoadjuvant therapy is a huge challenge that I don't think we do understand. In our MDT, as a rule, we say anybody who hasn't progressed should have a surgical exploration. And our surgeons say they can't tell until they get in. Really, it's very difficult to tell from the imaging what might be residual disease, what's just scarring. So we do take a fairly liberal view and give the benefit of the doubt, particularly to fit patients. The issue about staging, I absolutely agree. Better staging is important. We know PET has a role, and we do find lots of patients who have small volume liver metastases, for example, if we do PET, that we're perhaps not seeing just on CT. But even when we've screened those patients out, I think there still is a high burden of micrometastatic disease, which I think is why the neoadjuvant approach is probably the way forward.
Yeah, Dr. Prosenjit Chatterjee. Yeah.
Yeah, thank you, Dr. Jonathan, for an excellent presentation. So to correlate to Dr. Anthony's question, I have two quick questions to you. Do you feel the current imaging modality, the CT scan and MRI, are adequate predictors for this pathological response? And number two, the question remains the same for borderline resectable subgroup, that can we understand if the patients have not rather progressed with neoadjuvant chemotherapy? Are they the group we can be taken up for surgery, or we wait that if there is still unresectable, these patients who have undergone neoadjuvant chemotherapy should be taken up for surgery? That's a surgery-based question, but what is your experience and take on that, sir?
So, as I said, I think the current imaging modalities that we have, CT and MRI, are, well, we don't understand enough about how to interpret them, and in terms of response to neoadjuvant therapy. So I think that's a very difficult question, and more research is needed there. I don't think MR necessarily has any particular advantage over CT, because what you're particularly interested in is obviously looking at the vascular anatomy, which, you know, good contrast enhanced CT generally gives you the best information on. So no, I think it is very difficult. I don't think we really understand how to select which patient should go on to surgery. So as I say, our practice at the moment is to give patients the benefit of the doubt, because clearly surgery is really the only way at the moment those patients are going to be cured. Now, I guess as we move on with advances in radiotherapy and SABR and getting SABR up to higher doses, you know, we may have an alternative to dealing with those difficult surgical cases. But at the moment, really, we know the only chance of cure really comes with surgery.
John, if you don't mind, I would like to ask a question to you. This is Animesh. So you mentioned about SABR. So my question is it still in clinical practice for whether it's localized or locally advanced pancreatic cancer? Is it in clinical practice that you use SABR, or is it as a part of trial? We know about SPARK trial was closed because of toxicity concern, but is it now in clinical practice, SABR?
So in the position in the UK is NHS England have just commissioned pancreatic SABR for patients with locally advanced disease. So we are rolling that out. Many centres in the UK are training to deliver that. So for locally advanced disease, it is moving into our standard practice. And I think there is evidence to justify that. In the neoadjuvant setting, I don't think there is yet evidence, and I'd say definitely need for more research and trials there. And I think one of the big challenges is what dose of SABR we can get in with conventional techniques. So colleagues in Oxford, particularly using their MR-Linac, are running a trial looking at dose escalation on the MR-Linac, where I think that's much more feasible because you can give image-guided radiotherapy much more easily. So I think that's definitely an area to watch, and then that may then bring in a role in the neoadjuvant therapy. At the moment, at the place where we use that is in locally advanced disease.
Thanks a lot, John. Thank you for your valuable time and enlightening us with your knowledge and experience about neoadjuvant and adjuvant therapy in non-metastatic pancreatic cancer. I think we might have to close the session. If there's any burning question, we can just go with one more question. There are a few questions in the chat box. Yeah, there's one question from Dr. Shunita Prabhakar. Does all patients require adjuvant therapy? Those with no nodes or clear margin, do they need any adjuvant therapy? That's the question.
So the data from the SPAC group suggests that all subgroups benefit from treatment. So that I don't think we can identify a low risk group. Sadly, none of these patients are low risk. They are all at high risk of recurrence, and I think they all, those who are fit enough for treatment, I would recommend it. All should have adjuvant therapy.
Another question from Dr. Venkata Krishna Reddy. Would you suggest neo-adjuvant RT in any group of pancreatic cancer, or SPAC5 has closed the coffin for RT?
I think for borderline operable disease, I think what SPAC5 strongly suggests is that this is a systemic disease and patients need the most effective systemic therapy as early as possible. And I think the reason radiotherapy has perhaps not been beneficial in that group is it perhaps compromises the systemic therapy that we can give. I think, as radiotherapy techniques improve and we give better higher dose radiotherapy, there may be a role, particularly in inoperable disease, but I think that's very much an open question that needs further investigation.
Thank you, John. I think we'll close this session now. Before concluding the session, may I request our DMS sir to hand over a memento as a token of appreciation to our chairperson sirs, Dr. P.N. Mohapatra sir and Dr. Kingshuk Das sir. John, we wish next year to have you here for a physical conference. It will be wonderful to have you guys over here. Thank you. So we'll conclude this session and we'll be moving on to our next session, which is another interesting and often less discussed topic on neuroendocrine pancreatic cancer. And we've got Dr. Alan Anthony on screen. May I request our chairpersons for the session, Dr. Sheila Mitro, radiation oncologist, Apollo, Kolkata, Dr. Shubroto Saha sir, radiation oncologist, Apollo, Kolkata, and Dr. Vikas Kumar Agarwal sir, senior surgical oncologist at Apollo, Kolkata, to come over to the stage and chair the session. Over to you, sir and ma'am. Please introduce the speaker and start the session.
Thank you. To save the time, we will move on to the session itself. And we have a renowned personality, Professor Alan Anthony from Leeds, to discuss on the neuroendocrine tumor management, pancreatic neuroendocrine. So over to Alan.
Thank you very much. I'm just checking. Have you got my slides there?
Rahul, can you have Alan's
yes,
slide on the
screen?
screen?
Should we display it, sir?
Not yet, Rahul.
So just a second.
So I'd like, just while that's happening, so I'd like to thank very much the faculty for inviting me to talk about pancreatic neuroendocrine tumors and their management. And in the spirit of the whole conference, I thought I would focus on some aspects of pancreatic neuroendocrine tumor management which are controversial and probably haven't yet reached consensus. And it's because, being rare tumors than pancreatic neuroendocrine tumors, there's a relative lack of good clinical trial data to actually guide our practice. Next slide, please. So I was going to pick three topics. One is and as a non-radiologist, but as an oncologist who deals with neuroendocrine tumors, the difficulty with imaging of pancreatic neuroendocrine tumors and all the problems that arises. Then talk a little bit about management. So we've got a number of treatments, but we're still not quite sure what's the best sequence. And finally, something that I'm sure everyone who deals with pancreatic neuroendocrine tumors or pancreatic tumor boards finds increasingly: what would we do about the small incidental pancreatic neuroendocrine tumor? Next slide, please. And you might be asking, well, why talk about pancreatic neuroendocrine tumors? Because they're rare. So if you look at the data here from the American SEER database, there's been a significant increase in the incidence of pancreatic neuroendocrine tumors over the last 20 to 30 years. with certain inflection points showing an even steeper rise. And in the UK data, if you look at the bottom graph here, and this is all neuroendocrine tumours, again, over the last 20 years or so, this yellow line here, which doesn't show up very well, this is the pancreatic neuroendocrine tumours. So again, there's been a significant increase in the incidence of pancreatic neuroendocrine tumours. So it's something that we're seeing more frequently and having to deal with. Next slide, please. So as I say, the controversy is what is the best imaging method to use in the diagnosis and surveillance of pancreatic neuroendocrine tumours, and how many different imaging modalities are actually required to get the best treatment for patients. Next slide, please. So obviously CT scanning is the workhorse of all oncology, and it's usually actually where often neuroendocrine tumours and pancreatic neuroendocrine tumours are picked up. But the problem with neuroendocrine tumours in general and pancreatic neuroendocrine tumours specifically are the tissue density is very similar to the tumour, the organ from which they arise, and the vascularity of the tumours, they can be hypervascular or hypovascular. And so the actual mode of CT scanning can make a huge difference in terms of what we see when we get the results. So for example, in a non-contrast scan, thankfully somebody's put a little arrow in here, you can see there's a tumour in the tail of the pancreas with some calcification, which shows up a bit easier on an early arterial CT scan phase, but in the portal venous phase looks completely different. And we know that the sensitivity of CT scanning for pancreatic neuroendocrine tumours can be as low as 60%, depending upon the size of the tumour and depending upon the vascularity. Next slide, please. Perhaps more importantly is actually when we're dealing with metastatic disease, and this is something that happens very frequently, in that if we take it from C back to A, if you looked at this CT scan of somebody with a pancreatic neuroendocrine tumour that's metastasized to the liver, you can see that there's some indication of metastatic disease, but it doesn't look as though there's a very large tumour burden. Whereas then if you do a dual phase contrast in the portal venous phase, more of the lesions pick up. And then in the arterial phase of the scan, there's a significant tumour burden with a lot more disease. And the problem is that, and certainly in our institute, and I'm sure we're not alone across the world, even sometimes when you have two arterial phase CT scans that have been reported as arterial phase, very subtle differences in the contrast through the liver can make a big difference in what we can see in the CT scan. So it can sometimes be very difficult to tell whether a tumour is progressing or it's stable. And therefore, we nearly always have to take our scans back to our tumour board to get our expert radiologists to deal with the phase, deal with neuroendocrine tumours, because it can be very difficult sometimes to know what's happening to the tumour. So CT is what we all have, but it's got lots of issues related to it. Next scan, please. Oh, sorry, next slide. So what about MRI scanning? Is MRI better? Well, again, looking at a tumour in the tail of the pancreas, you can see in the different scanning phases on CT, whereas in the liver, when you do a diffusion weighted MRI scan, a liver specific MRI scan with diffusion weighting, this is the best method of looking at the liver and shows up an awful lot more in the liver in terms of metastatic disease than CT or even non-liver specific MRIs. And so certainly one of the things, and particularly this can be very useful in lots of patients now who have fatty liver and fatty liver after chemotherapy. If there's an accumulation of fat within the liver, it can be very difficult to image the liver with neuroendocrine tumours. The problem is that MRI scans are fewer than CT scans, and they only focus in certain parts of the body rather than the whole body. So there are certainly patients who you need to do an MRI scan and a CT scan, and that obviously builds up the cost and the inconvenience for the patient. Next slide, please. So neuroendocrine tumours particularly are very heavily reliant on functional imaging, and the functional imaging can have certain specific, has importance for the management of neuroendocrine tumours. So the functional imaging predominantly based on the fact that neuroendocrine tumour cells or neuroendocrine cells have somatostatin receptors on the surface, and somatostatin receptors 1 to 5, with different ligands such as octreotide binding strongly or less strongly to the different receptors. So if your neuroendocrine tumour cell expresses somatostatin receptors, it should bind these ligands like octreotide or pentetriotide, and you can radio label them, and this will show things up. And since 1994, using indium 111 pentetriotide and the octreotide scan, that has been the beginning of functional imaging in neuroendocrine tumors. But we know that that's not the most sensitive method. And in the last 10 years or so, the use of new PET tracers using a positron emitting isotope gallium-68 bound to these various somatostatin receptor binding molecules is far more sensitive. All have been shown to have similar clinical effectiveness, but they're all more sensitive than octreotide scans. And as you can see from this graph or this figure here, looking at the liver, you can see there's some uptake on the octreotide scan, but when you do the gallium-68 dotatate PET scan or dotatalk PET scan, you get an awful lot more sensitivity and a lot more lesions showing up. One of the problems about the octreotide scan in pancreatic neuroendocrine tumors is in the case of insulinomas, because insulinomas, only about 50% of insulinomas will show up on an octreotide scan. And although with a gallium PET scan, because many insulinomas, particularly small ones, don't express somatostatin receptors, that sensitivity comes up to about 85%. One interesting point to note is that there are other tumors and other benign conditions that will also express somatostatin receptors. So I've certainly been caught out in the past with a patient who had tuberculosis and a large tuberculoid granuloma, which showed very strongly positive on an octreotide scan. And other tumors such as small cell lung cancer, but also renal tumors and cholangiocarcinomas can sometimes show up as well. So we've got to be aware of that. Next slide, please. But the main point of this part of the talk I wanted just to touch on was, can functional imaging actually give us any indication as to the biological behavior of our neuroendocrine tumors? So there's an increasing interest and trend to say, well, what role does 18F fluorodeoxyglucose PET play in the role of neuroendocrine tumors? So the perceived wisdom till now is that well-differentiated, well-behaved neuroendocrine tumors, you should scan them with an octreotide scan or a gallium PET scan. And the grade 3 neuroendocrine tumors heading off towards the kind of the smaller cell end of the spectrum, because they're metabolically much more active, then we should use FDG PET. But can FDG PET tell us anything about the biological behavior of the grade 1 and the grade 2 neuroendocrine tumors? And if you look at this image here, this is the gallium PET showing lots of uptake and activity. But when you do an FDG PET, some of these lesions also show up in the FDG PET. And could that be saying that they potentially are more metabolically active and therefore perhaps are likely to have a worse outcome? So from the Royal North Sydney Hospital in Australia, they came up with this net PET score where patients had a gallium PET and an FDG PET done within about a month of each other. And depending upon the SUV levels, the uptake of the binding of the gallium or the uptake of the FDG, they made a score for those where it was strongly gallium PET positive, but with no uptake in FDG PET, right up to the opposite, where they were strongly positive in the FDG PET and negative in the gallium PET, and then various differences in between for those that took up both receptors. And when they looked at that in terms of survival, so this is the F1, this is the strongly octreotide positive, this is the strongly FDG positive, and this is the group in between. You could start to differentiate patients in terms of their likely outcomes. So it might be that this, using these two functional imaging techniques, might be able to give us better prognostic behavior. Next slide, please. And in a similar way, this is the group from Bad Berka in Germany, where they looked at a much larger number of patients, including pancreatic neuroendocrine tumor patients. And this was saying, could FDG PET give an indication as to the likely benefits in such patients from giving targeted radiotherapy? So all of these patients had gallium 68 PET positive tumors that were all going to receive targeted radiotherapy using Lutathera. But those patients who were FDG positive had a much worse overall and progression-free survival than those patients who were FDG negative. So again, it might allow better selection of patients, and some patients who the targeted radiotherapy may not be as effective. This is all retrospective data, unfortunately. There's no prospective studies, and as yet, looking in clinicaltrials.gov, I could only see 2 small studies currently running in Canada to try to look at this. And just asking my nuclear medicine colleagues, The problem is doing 2 scans regularly. So an FDG PET scan probably costs about 80,000 rupees NHS prices, whereas a gallium PET scan costs about 150,000 rupees. And if you were going to do that in every patient you had coming through, again, certainly in the National Health Service in the United Kingdom, we would want very strong evidence to know that this was really benefiting patients. Next slide. So the next question is, what's the best treatment to give for pancreatic NETs, and what's actually the optimal sequence? Next slide. So for well-differentiated pancreatic neuroendocrine tumors that are positive on an octreotide scan, we know that the somatostatin analogues, octreotide and lanreotide, can, as well as controlling hormonal symptoms, can also have a disease-modifying effect. And in the Clarinet study, which is now 10 years old or so, for patients who had slowly growing disease, so these weren't rapidly growing tumors and they had a Ki-67 of less than 10%, there was a definite progression-free and ultimately overall survival benefit in patients who had lanreotide. And this study, as opposed to the PROMID study, which didn't include pancreatic neuroendocrine tumor patients, but certainly shows for pancreatic neuroendocrine tumors that this is and I think most people around the world for slowly growing PNETs would probably use a somatostatin analog in the first line. We also know for slightly more higher grade tumors, with those with a Ki-67 greater than 10%, again, somatostatin analogs are beneficial with a median progression-free survival of 11 months, with good prognostic features being a low liver tumor burden and grade 2. And even in people who were progressing on lanreotide 120 milligrams, if you doubled the dose by halving the frequency of injections, again, you could still regain some control. So the somatostatin analogs are definitely effective treatments. Next slide, please. And what about chemotherapy? Well, again, pancreatic neuroendocrine tumors, as compared to many other neuroendocrine tumors, have good evidence behind them showing that chemotherapy can be helpful and be effective. And there's a range of chemotherapy drugs. The current international standard seems to be temozolomide and capecitabine, but in the past, we've also used streptozicin and lomustine. So a combination of an alkylating agent and a fluoropyrimidine seems to be beneficial to many patients. This was the original TEMCAP data from Matthew Kulka, showing a really impressive waterfall plot, and then some pictures where you get remarkable responses to chemotherapy. Next slide, please. And then we also have the small molecule TKI inhibitors, the mTOR inhibitors. So again, this is randomized controlled data from some time ago. So all these patients had progressed upon somatostatin analogs. But with sunitinib, again, we could show that by being in sunitinib, there was an overall survival benefit compared to placebo, with a very impressive progression-free survival benefit. And I'm sure everybody who treats pancreatic neuroendocrine tumors have had a few patients. I got one lady I saw yesterday who's had stable disease for 7 years on her sunitinib. And the same with everolimus. Again, these were all patients who had progressed in somatostatin analogs, and everolimus had a significantly improved progression-free survival. But the question has been, well, actually, we've now got chemotherapy, we've got TKIs and everolimus. Which treatment's best? Which one should we use after progression on somatostatin analogs? Next slide, please. And so this study that was presented at ESMO in September last year in Paris, run by Professor Ramon Salazar in Barcelona, was the SECTOR study. And this was a study saying that in patients who had progressive disease, it was a randomized crossover study by patients starting on everolimus and then switching over to streptozicin and 5-FU as the chemotherapy, or the other arm B was patients starting in chemotherapy and on progression switching over to everolimus. And this was an interim analysis of the results of the first progression-free survival. So was there a difference between either of these treatments in controlling the disease longest when used as a first-line salvage therapy after somatostatin analog treatment? And you can see from here that there was really very little difference. Both had a non-significant difference between the arms in terms of the primary endpoint, which was 12-month progression-free survival. However, you can see again, there's more patients in this arm. So it's about, I think it was over 20% of patients had actually a response in terms of complete response or partial response, whereas it was only about sorry, this was about 30%, where it was just as about 11% of patients with the everolimus had any shrinkage of the tumor. So the take-home message from this trial was that if you needed tumor shrinkage from symptoms, either bulk symptoms or from hormonal symptoms, or patients were just unwell because of the progression of their tumor, then you were probably better off starting with chemotherapy. But we're still awaiting the survival advantage to see if there's a difference between the sequencing in terms of overall survival. Next slide, please. And again, we also know that many of these patients will be positive on octreotide scans or gallium scans and would be candidates for PRRT. So is there a difference in terms of patients progressing after somatostatin analog therapy who would be candidates for targeted radiotherapy? Are you better giving them the targeted radiotherapy first, or are you better giving them something like sunitinib? And again, Eric Bodan from Gustave Roussy presented at ESMO a study called OcuLrandom, in which half the patients went on to receive lutetium dotatate and the other half went on to sunitinib. And it wasn't a comparative study trying to find out which arm was best, but it was seeing whether they met a predefined endpoint to say whether it was worth considering taking on or whether it looked as though it might be a treatment that was beneficial. And there was a definite trend towards PRRT treatment being more effective as a second-line treatment in these patients rather than going on to sunitinib. And because there is some evidence to say that the more treatment, particularly chemotherapy treatment you have before using targeted radiotherapy, might increase the risk of bone marrow toxicity down the line in terms of myelodysplastic disease or leukemias, then it might be that we need to use this treatment in certain patients sooner rather than using other chemotherapy drugs or molecularly targeted agents. Next slide, please. And then finally, and hopefully quickly, because I know we're running out of time. So increasingly, I remember the graph from the very beginning showing the incidence of pancreatic neuroendocrine tumors rising rapidly. The reason for this is as more and more of our patients have CT scans, we're picking up more and more small incidental pancreatic neuroendocrine tumors, which may have been there for years beforehand and not caused the patients any symptoms. But once we've detected them on scans, we don't know what to do. And so it's a big debate at all our tumor boards is to say, should we operate? Should we keep them under surveillance? What do we do about them? Next slide. And this is what we're talking about, these small incidental pancreatic nets. And as I say, there's been a significant rise in the small nets from 12% to over 20%, and that's up to 2009. And I'm sure that's much higher because of this increase in CT scanning. So the international guidance from ENETS and the NCCN base their decision-making on size. So above 2 centimeters, they suggest that patients should undergo surgical resection. But if you've got a PNET, a small PNET in the head of the pancreas, that's a pancreaticoduodenectomy and a lymphadenectomy, which is not a minor undertaking. For those tumors less than 2 centimeters, then it's a lot less certain. And they say, well, you need to have a discussion with the patient. Next slide, please. So really, does size make a difference with pancreatic neuroendocrine tumors? And this American epidemiological SEER data covering 50% of the United States would seem to suggest that at all stages of disease, whether localized or regional or even distant, the larger your tumor to start off with, the worse your outcome. But the problem with this data is that it's epidemiological data. It's not prospectively collected trial data. And there's lots of confounding factors. So many of these patients had surgery. Many had metastases to even start with. Some had high-grade disease. And we can see from this part of the data that this was above and below 2 centimeter patients who'd gone on to have surgery. The cancer-specific survival wasn't different, but the overall survival was different because for people who didn't have surgery, because many people who didn't have surgery because they were elderly or they were unfit. And so therefore you can't really take size as the major defining principle. Next slide, please. So this was a meta-analysis looking at small studies. So there wasn't many patients in these studies where patients with pancreatic neuroendocrine tumors that had been detected incidentally had been put on surveillance rather than going straight to surgery. And essentially, although the numbers were small, this suggested that there wasn't really any detriment to patients by undergoing surveillance, that if you underwent surveillance and the tumor continued to grow, then surgery at that point was equally as effective in getting rid of the disease, and there wasn't an increased risk of metastasis. Next slide, please. And this is a really interesting Canadian study where they looked at tumor growth rate depending upon initial size of the tumors. So people who were kept under surveillance for a variety of reasons, obviously most of these tumors were less than 2 centimeters in size. But what they showed was that even larger tumors, some small tumors grew very rapidly, some larger tumors actually got smaller in size. So size itself isn't the critical thing. It's much more likely to be other biological parameters of the tumor that are important in determining how they behave rather than initially size. Next slide, please. And thankfully, we've had the ASPEN study. So the ASPEN study, a study led by Massimo Falconi from Italy, was trying to answer this question. So it was a 1,000-patient prospective observational study. Impressive that it ran through COVID, and basically individual institutes could decide whether they would operate upfront on pancreatic neuroendocrine tumors or they would keep them under surveillance. And they were looking for, it was a very systematized way of following patients up to try and get information as to what was the best approach. Next slide, please. And this was an interim analysis, so a very early analysis. But basically, the 406 patients who underwent surveillance, that the majority of these, and these all had EUS-guided biopsy to start with, so the majority were grade 1, they were generally small, and a very few on the radiological staging had lymph nodes. In the surgical group, and again, this is the preoperative analysis, far fewer patients had endoscopic ultrasound-guided biopsy because they were going to go on to surgery, so there seemed to be perhaps a higher number of grade 2 and even some grade 3 patients. But post-op, in fact, there was still about the same number of grade 1 patients, and there was one patient who had a higher grade tumor. So I suppose what that says is surgery can occasionally pick up those patients who have a higher grade. But what they showed was, in fact, there wasn't really any difference so far in the progression-free survival between patients who were kept under surveillance as opposed to patients who had undergone upfront surgery. Again, probably saying that there's no harm to patients if you keep them under surveillance initially, although the problem is what we don't know is how long patients do need to be kept under surveillance. And for younger patients, that could be decades. Next slide, please. We do know that by doing EUS-guided, endoscopic ultrasound-guided biopsies from this, that tumors less than 2 centimeters in size and who then go on to have resection, that the grading of the neuroendocrine tumor got by biopsy is very highly concordant with that got from surgery. So for small tumors, doing an EUS-guided biopsy will give you a very good indication as to the grade of the tumor. And it's probably the grade of the tumor that's more important than the actual size of the tumor. Next slide, please. There's an interest in whether we can use EUS-guided ablation rather than surgery to get rid of these tumors. And these are some small studies done which showed, again, that fact for many tumors that were ablated, and that's certainly a technique used for tumors that are producing hormones and that can't be operated upon and are quite symptomatic. But it probably also allows us to have long-term disease control with relatively modest side effects. Next slide, please. And then in terms of surgical options, there's a debate regarding whether patients should have minimally invasive or open surgery versus enucleation. And obviously enucleation is advantageous because it's less traumatic for the patient, but it doesn't remove lymph nodes. And there's always a concern that if there's lymph node metastatic disease or micrometastatic disease, that might be what causes recurrence in the patients. Next, please. Next slide, please. And this is the last slide, and it probably doesn't show up very well. But basically, this was the difference between those patients who underwent enucleation and patients who underwent open surgery, depending upon size. And the 5-year overall survival rate was really almost not different at all. So I think that says that for patients who do need surgery, that enucleation, if it's possible, is as equally as safe as doing a major operation. So I'm sorry to have rushed through that at a high rate, and particularly the last bit about small pancreatic neuroendocrine tumors, because it's still we still discuss it at our tumor board on a regular basis, and I don't think we really have an answer to that. But I hope it's shown some of the controversies around pancreatic nets, and I'm happy to take any questions. Thanks.
Thank you, Professor Allen, for a lovely coverage of neuroendocrine tumor. So I would ask any questions from the hall. For the sake of time, 1 or 2 small questions only. Is there any question in the chat box?
Okay. I think we don't have any questions.
Okay.
So thank you, Alan. Thank you for the excellent talk and your valuable time. Thanks
Thank
for
you.
enriching our knowledge about pancreatic neuroendocrine cancer. Before we move on to our next session, may I request our DMS sir to present a memento to our chairpersons as a token of appreciation.
We are taking on your behalf, Alan, also.
Thank-
Thank you.
Thank you. So we'll conclude the session here. So moving on to our next session, a very interesting debate. It's probably a debate between a medical oncologist and a radiation oncologist. And to chair the session, we have our medical oncologist, Dr. Amit Dattadwari, sir. Okay. So may I request Dr. Prashanjit Chatterjee, sir, to come over and chair the session. So I would request Prosenjit sir to introduce our debater for the next session.
Good evening. So, as we know, debate is a very important anthem of a academic session, and we have got an interesting topic today. The motion goes, neo-adjuvant chemo-radiotherapy is better than neo-adjuvant chemotherapy in esophageal cancer involving lower third and GE junction. And we have got two distinguished debaters today. Both of them are medical oncologists. Dr. Mohan Hingorani from Leeds Cancer Center, he'll be speaking for
Dr.
the
Mohan is
motion.
a clinical oncologist.
Clinical oncologist, okay. And Dr. Vamshi is my good friend. He'll be speaking against the motion. He's from AIG Hospital, Hyderabad. So I would request Dr. Mohan Hingorani to start the session. It's all over to you, sir.
Yeah, okay, thank you. Can you hear me, yeah? Can you hear me there?
Yeah, we can hear you.
Can.
Okay, good. Can you share my slides, please, yeah? So thanks, yeah, thank you for inviting me to give this presentation. So I'm actually going to convince you at the end of my talk that neoadjuvant chemoradiotherapy is superior compared to neoadjuvant chemotherapy in cancers of the lower esophagus and the gastroesophageal junction. So before I start, I just need to let you know I'm a consultant clinical oncologist working in the UK. I have been working for Hull University Teaching Hospital NHS Trust and have worked for Leeds as well before, but currently I'm employed by Hull University Teaching Hospital NHS Trust. You got the logo at the top and you got the image of our center as well. So next slide, please. So what's the evidence for the neoadjuvant chemotherapy or chemoradiotherapy? I think you need to summarize that to have a bit of understanding as to which one is superior, if at all. So this is the slide which is actually taken from the ESMO guidelines for management of esophageal cancer. And what this shows is that they recommend that patients with esophageal cancer who are potentially curable should be staged with the US and the PET scan. So I guess the PET scan is important to exclude any possible distant metastases, and endoscopic ultrasound is important to for local staging of the tumor. And then if you look at the algorithm, you can see for squamous cell cancer, there's no controversy really, because the two options are either you give them definitive chemoradiotherapy or you give them neoadjuvant chemoradiotherapy followed by surgery. That's based on the cross data. However, for adenocarcinomas, which are prevalent in the lower esophagus and the gastroesophageal junction, it specifies both options, that they could have neoadjuvant FLOT or they could have neoadjuvant chemo-radiotherapy. So based on that algorithm, you'd feel that both are accepted standards of care, and it doesn't specify which modality would be appropriate for a particular subgroup of patients. So we're going to look at the data for both chemotherapy and chemoradiotherapy, and then try and see which one is better. So can we, next slide, please. So for the neoadjuvant chemotherapy, we're going to just review the randomized key studies. So next slide, please. So the three key randomized studies from the past were the first one was the MRC OYO2 study. So this was a very old study done in 2002. It's an MRC UK study where patients were given 2 cycles of platinum and 5-FU and then went on to have surgery. And it showed a survival benefit at 6 years, a small survival benefit from 17% to 23%, but was statistically significant. And the patients who had chemotherapy had a higher incidence of tumor downstaging and also higher incidence of a pathological complete response. And then it's about 10 years later that we had our own MAGIC study, actually, which was the STO2 study, again, MRC study, which was a pivotal study, where patients were given 3 cycles of neoadjuvant ECX, which was epidubicin, cisplatin, capecitabine, and then surgery, and then further 3 cycles of ECX after that. But the important thing to highlight is that MAGIC study actually had 75% of them were gastric cancers and only 25% of them were esophageal cancers. It was not a purely esophageal cancer study, but nevertheless, it did show a 5-year survival benefit of 14%, so a huge benefit with a hazard ratio of 0.75. Around the same time, there was a French study as well, which looked at very similar design to the MAGIC study, which had 224 patients with esophageal and stomach cancers, but the distribution was reversed. So unlike the MAGIC, actually, you had 75% esophageal cancers and 25% stomach cancers. And that used actually 2 to 3 cycles of platinum and 5-FU. So they omitted the epidubicin. So there was no epidubicin there, and they used 2 cycles of platinum, 2 to 3 cycles of platinum 5-FU, pre and post-op. So very similar to MAGIC, and showed it, identical results. So the 5-year survival again for this was 38% for the experimental arm and 24% for the surgery alone arm, with a hazard ratio of 0.7. So basically, we have 3 randomized studies showing a survival benefit for neoadjuvant chemotherapy using mainly platinum 5-FU, although in the MAGIC there was epidubicin as well. But more recently, I think that's been dropped from the treatment protocols where platinum and 5-FU is used. Next slide, please. However, the most pivotal study has been the FLOT study, which was published, which was actually presented at ASCO in 2017, which was comparing the FLOT with the standard of care, which was ECX at that stage. So basically, patients were randomized to either have 3 cycles of preoperative and adjuvant ECX or 4 cycles of pre and post-op FLOT. And what it, and we'll just look at this study a bit more in detail. Next slide, please. Yeah. Your next slide, please. Yeah. So in the FLOT study, as you see, there were 716 patients which were randomized to either FLOT or ECF and ECX. And they were basically patients with either gastroesophageal or esophageal. So basically type 1 or type 2 GOJ cancers or gastric cancers. Next slide, please. That was the regime, which I'm sure we all are familiar with. So it's using docetaxel, oxaliplatin, and 5-FU. Next slide, please. So this is the distribution in FLOT, actually. And as you can see, I think most patients were less than 70 years of age, with only 25% of patients more than 70 years of age. Most patients had a ECOG status of 0 to 1, and there were about 45% stomach cancer patients, but the rest were either type 1 or type 2 GOJ cancers. Next slide, please. So can we see that? So we can see here that there was a significant survival benefit. The median overall survival was 35 months for ECX and 50 months for FLOT, with a hazard ratio of 0.7, and the 10% survival benefit at 2 years, 3 years, and 5 years. So based on that, FLOT actually became one of the standards of care. And any patient who's probably fit for FLOT has FLOT, and if they're not fit for FLOT, then they either end up having platinum or 5FU. So based on that, so that's the summary of the neoadjuvant chemotherapy. We now need to look on the chemo-radiotherapy side of things. And next slide, please. Sorry, and this is just to summarize the toxicity from the FLOT study. So as you can see that in the FLOT, actually, there was about nearly about 50% patients had neutropenia, and there was a high incidence of infections as well, and there was about 10% risk of diarrhea. Next slide, please. And there was about the 35% grade 3 toxicity for both arms. So 1 in 3 patients did suffer grade 3 toxicity. Next slide, please. So going on to the chemoradiotherapy side of things. Next slide, please. So this was the pivotal cross study, which actually established the standard of care for chemoradiotherapy in esophageal cancer. So this was a study which was done it was a Dutch study with 8 participating Dutch centers, which randomized 368 patients with either esophagus or type 1 or type 2 GOJ cancers to having pre-op chemoradiotherapy followed by surgery. And this used 41.4 grain 23 fractions combined with carboplatin, AUC2 and paclitaxel 50 milligram per meter squared weekly. Followed by surgery at about 4 to 6 weeks, and the standard of care at that stage was surgery alone. And the patients were actually had to be locally advanced, so either they had to be T2 or higher with presence of N1 N+ disease, and it included both squamous cell carcinomas and adenocarcinomas as well. And next slide, please. But apart from the cross study, there were other 2 studies as well before cross, which had shown a possible survival benefit of chemoradiotherapy. One was a very old study, which was a Welsh study, it was an Irish study published by Welsh et al., which showed that 2 cycles of 5FU and cisplatin combined with 40 grain 15 fractions did induce a significant improvement in survival. And then there was another CLGB study, which was in 2008, which was actually had to be stopped early, so they could only recruit about 50 patients. But it still showed there was significant survival benefit with chemoradiotherapy, again using 2 cycles of platinum and 5FU, which induced a median overall survival of 4.5 years with the chemoradiotherapy compared to 1.7 years with the surgery alone. So there were already 2 positive studies before cross came on board. So it was not like we did not have any data for chemoradiotherapy. However, most people were reluctant to adopt chemoradiotherapy as standard of care because of concerns regarding postoperative mortality. And that was because there were some studies which were done, which showed there was a higher postoperative mortality, but we have to understand at that time, the radiotherapy technology was very old, and we were using, and that has significantly advanced now. So it could be that at that stage, there was no optimization of the dose received by the lungs or other things, which probably may have contributed to the increased postoperative mortality in that study. However, when the cross was, the results from the cross study, however, showed that there was no increase in postoperative mortality, and it was very low. It was 4% in both the groups, which was reassuring. Now, looking at the results of the cross study, next slide, please. So this is the distribution of the patients. So it's a cross study not had very, the other impression is that cross study had very early cancers. That's not true actually. And the other impression is that it mainly has squamous cell carcinomas. That's not true as well. In fact, 75% of patients in the cross study had adenocarcinomas. Most cancers were lower esophagus and the GOJ. And about 65% of them had N1 disease. So it also had a substantial proportion of adenocarcinomas and locally advanced disease and node positive disease. So looking at the data from this cross, actually, as you can see, the 5-year survival for this whole group was 47% compared with 33%. And for squamous cell carcinomas, it was huge with a hazard ratio of 0.5, but there were only 25% of patients had squamous cell cancer. But for adenocarcinomas, the hazard ratio was 0.75, but it was still statistically significant. I think there's again this thing that the cross study didn't show a significant benefit for adenocarcinomas. That's not true. I know the confidence intervals they'd reached to 0.98 for hazard ratio, but still it was statistically significant. And the 5-year median overall survival was 43 months compared to 27 months. Next slide, please. I think I've just put these side by side. So if you can look at cross and FLOT data, you can see that with the cross, I think there's a higher incidence of pathological complete response and not resection compared to the FLOT study. I know there were 2 independent studies, and I'm not saying that we can make a like-to-like comparison, but what I'm trying to say is that we do see high incidence of PCRs with chemo-radiotherapy and also high incidence of not resections. And if you look at the hazard ratios, they're very similar, 0.75 for both the studies. And the 3-year and 5-year survival is very identical. So basically, they are both very effective therapies, and we can't say one is better over the other, but the advantage which cross has over FLOT is the toxicity side of things. Because the grade 3 hematological toxicity was only 7% in cross, and the hematological toxicity was only 13%. If you compare that with FLOT, then basically you have a grade 3 hematological toxicity. The hematological toxicity was only 25%, but the overall grade 3 toxicity was about 35%. So that's nearly 2.5 or 3 times of what the cross showed. So cross does have a significant benefit in terms of reduced toxicity. However, in the cross, there was one inclusion criteria was tumors had to be less than 8 centimeters. And the other thing we have to say is that although 65% of the patients in the cross had node-positive disease, FLOT had about 80% of node-positive disease. So it is possible if you have a higher incidence of nodal involvement, then FLOT may be better in those patients. But next slide, please. So to summarize, I think both cross and FLOT are extremely effective neoadjuvant therapies. Cross regimen is better tolerated with less significant grade 3 or higher toxicity. In our center and elsewhere in the UK as well, I think cross is often preferred compared to FLOT if the length of disease allows chemo-radiotherapy to be delivered. And the important thing we have to understand is that if for very long length of disease, this is not an option. I think ideally the tumor should be less than 8 centimeters. And we have to be carefully looking at the lung DVHS. And I think we normally look at V20, but if you're giving neoadjuvant chemoradiotherapy, we should be looking at V5 and V10 as well, because the lung doses may determine the postoperative mortality. And the stomach extension should not be less than 3 centimeters. Otherwise, you'll radiate most of the stomach and they won't be able to use the stomach to form the esophageal conduit. And the extent of nodal involvement is probably important as well. If you've got more than N2 disease obvious on the staging, then I guess we may have to probably go for FLOT, because FLOT may be more appropriate with high extent of nodal involvement. Next slide, please. So this is the I'll just conclude by our own algorithm. So we use both FLOT and cross, and basically our patients do have an US and PET scan. And then we look at the length of the disease. Actually, if it's less than 8 centimeters, there's limited nodal involvement, less than N1 on US and PET, and there's limited gastric extension with adequate cardiopulmonary function, you probably give them chemoradiotherapy. So we prefer that over FLOT, and that's a group of patients. However, if the length of disease is more than 8 centimeters, there's extensive nodal involvement, where we feel cross may not be the best thing, then we go for FLOT chemotherapy. And if patients can't have either, because there are some patients who are not fit, then we go with the MRCOU2 protocol of giving them 2 cycles of platinum and 5-FU followed by surgery. So all those 3 options are there. So basically, I think that chemoradiotherapy has got the advantage compared to FLOT, compared to chemotherapy, compared to especially to FLOT chemotherapy, the advantage about reduced toxicity. However, it can only be delivered in a specific group of patients. Thank you.
Thank you, Dr. Hingorani. That was an excellent deliberation. You categorized it nicely about the protocols and guidelines followed in your hospital. And now I will request Dr. Vamshi to start firing. Are you there, Dr. Vamshi?
Yes, I am very much there. Thank you.
Yeah, please start.
Okay, so good afternoon, everyone. My topic is chemotherapy for all in EG cancers. The G junction is what I'll be focusing on. I'm lucky enough to work in a center with a lot of GI work, so we do see these patients quite often. And the next 10 minutes or so, we are running slightly late, so I'll just try and finish it off in 10 minutes. Talk of how chemotherapy is what should be preferred for everybody. Next slide, please. Now, this is where we are. We are looking at the lower G junction. We are not going to go beyond into the stomach. We are not going to talk only exclusively of the esophagus. I will make the concession and accept, yes, most of my data is for the adenocarcinomas. For the squamous, the data for neo-adjuvant is really not there for larger centers and larger trials from the Western data. I will talk about a Japanese trial, which did have that subset as well. But by and large, what I'll be focusing on is on lower GE junction and the adenocarcinomas. Next slide. So why do we give neo-adjuvant chemo? Let's be honest about it. We need to downstage the tumor. We would want to treat the micrometastatic disease. And finally, very importantly, we need to improve our overall survival. So let's see what neo-adjuvant modalities we have for doing this. Next slide. Again, I'm not going too much into individual trials, but let's first start off with the major trial that actually established the role of chemotherapy. That was the MRC trial. Now, this trial has a lot of criticisms for very valid reasons. Biggest, of course, is that you're comparing chemotherapy versus only surgery. Now, I'm sure my opponent must be hearing a ringing bell because that was what was done in the cross. You know, you had a trial where you compared surgery versus a neo-adjuvant followed by surgery, right? So any criticism of magic has to be tempered with the fact that, well, radiation has done the same thing. So in this study, they used 3 cycles of preoperative ECF and had 74% of gastric tumors. Only 12% were GE junction. Okay, point to be noted on that. Next slide. Now, when the results came, the PFS was better, the OS was better. Next slide. The next other trial which we included was the FFCD trial. Now, FFCD had something similar. They used a cisplatin 5. Again, look at the drugs. You had ECF, now you have CF. Again, in this trial, when you look at the number of G junction, this is 62%. So much, much higher percentage of G junction. That's what we are talking about today. Next slide. Now, in this trial as well, when you had the final results, it showed you a benefit with giving preoperative chemotherapy. Now, the absolute benefit in overall survival is 14%. Again, remember these numbers, 24 versus 38, right? 24 versus 38, 14% absolute benefit with chemotherapy. Next slide. So then came the FLOT. Now, FLOT is a only study, one of the only studies, which actually has 2 arms that are perioperative or neo-adjuvant, right? This is the biggest advantage or the biggest benefit that we see with the FLOT study. You have 4 cycles of FLOT versus 3 of ECF. Now remember, 3 ECF is proven to be better than only surgery. So this trial, they actually tried to see what happens between 2 perioperative protocols. Next slide. The results were rather clear that the benefit was better when you looked at FLOT in terms of the R0 dissection rate, 84%, surgery undergone in 94%. Again, if these look familiar, these are because this has been covered by my opponent. He talked about cross and the R0 dissection rate, just almost the same as this. Talked about the surgeries, which is the same as this. Talked about the morbidity. If you look at post-op mortality, which is similar in both the arms. So perioperative FLOT increases the proportion of patients undergoing surgical resection, increases R0 compared to another preoperative protocol. So that's the takeaway. Next slide. Now, when you talk of FLOT, the other part which we need to look at is the is the PFS and the OS. In both the cases, it is better than ECF. Now, focus here on the hazard ratios. It's 0.77 with the hazard ratio being significant. Both here it is 0.75, right? Look at the projected 5-year survival rate, 36 and 45% for FLOT. Again, remember, we have had data from my previous speaker who talked about cross 5-year survival, which is still almost the same, 40 to 43%. So you are basically having two trials. I agree, cross trial comparison is difficult, but both the trials are showing the same kind of high OS over the 5 years. Next slide. The benefit for this is preserved for all comers, and that is where the differences start coming between the trials. FLOT showed benefit for T3, T4, showed benefit for node positive, showed benefit for node negative studies, for node negative patients as well. That is very crucial. Next slide. So what about this preoperative chemoradiation other than cross? Multiple small studies, benefits in PFS, results are generally better for the esophagus, not much for the G junction. Next slide. This is the cross paper where, next slide. So this is the cross where you had 368 patients. Remember, FLOT was 776 patients, including both the arms. Here it's only 368 patients. Here, most of the patients were actually adeno, 75% were adeno. G junction around 20% of patients. Next slide. Now, this is what has not been pointed out by my previous speaker. Look at the subset. Now, you can argue that subsets are something that you don't talk about, but when you are having this kind of number of patients, look at the adenocarcinoma here. 0.732, 0.998. It's almost touching the unity. Just about going close. But then when you look at the adjusted hazard ratio, according to the trial itself, it has now crossed the unity. So your benefit here is not so much. More interestingly, look at what's happening in node positive disease. 0.793, 0.807. So essentially, a node positive disease, which is actually more risky, is where your cross is not showing a benefit. Whereas FLOT showed a benefit in all of these subsets. And again, if you remember my opponent's last slide, their protocol, whenever it's node positive, whenever it's larger in size, let's not go for CTRT, let's go for FLOT. Because essentially, FLOT is the better protocol for such patients. That's an implicit admission in his own algorithm, and that's what I also completely agree. And I thank him for showing that slide because it just proves my point and my point of the debate. Next slide. Finally, next slide. The critic study did not again show any benefit of the CTRT. What about any network meta-analysis? Now, meta-analysis have been done. There are multiple. I have shown one. I'm sure there are others which can be shown. By and large, what most neo-adjuvant show, next slide, is that both CTRT and chemo are beneficial. But as a network meta-analysis, probably perioperative FLOT is the one most likely to be effective as a neo-adjuvant treatment. Next slide. So then we come to the neo-edges, something that was conspicuously absent from my previous speaker's study, my previous speaker's slides. Now, neo-edges tried to look at phase 3 cross versus perioperative that was modified MAGIC or FLOT. Very interesting. You have MAGIC, which is inferior to FLOT, and yet, next slide, when you look at the number of patients, most of the patients, actually 80% of the patients actually were from MAGIC, not with FLOT, which is a better regime. Only 27 out of 184 were MAGIC, FLOT protocol. Then look at the overall group, 84% T3, C node 1 was 60%. Now the initial power calculation was based on cross being superior at 10%. Then after first futility analysis, the program was changed to a non-inferiority with a margin of 5%. That's a swing of almost 15% from one side to the other. And even on that, the DSMB had to recommend closure of recruitment because there was no probability of survival. The probability of survival is 56 and 57, hazard ratio 1.02. So that's how the neo-edges played out. So a trial which compared directly FLOT and cross found that there was no benefit, even though the very nicely worded statement says that perioperative chemotherapy, there is no evidence that perioperative chemotherapy is unacceptably inferior to multimodality therapy. So make what of you as it, multiple negatives in the statement. Essentially, CTRT is not better. Next slide. We, of course, have the ESOPEN data, which we are awaiting. But what we need to remember is that even in Japan, which has a much higher percentage of squamous carcinomas, neo-adjuvant chemo is the standard of care, not CTRT. And the reasons are these. Let's come to where we are. We are in India. Now, this was a small single center study which showed in 50 patients CTRT with 90% squamous patients. The completion rate of chemo is only 50%. And the R0 and overall resection rate is only 64%. Adenocarcinomas were majorly non-responders. Next slide. Coming to TMH data from the Tata Hospital, in 2020, they published it, and they showed 268 patients with 97% completion rate of NACT, with 66% completion of adjuvant with an R0 rate of 93% with a 5-year OS of 37.6%. Remember, the cross 10-year update has still shown a benefit of overall survival of close to only 14%, absolute numbers. But the total number is only 26%. So again, Indian data also suggests that FLOT is a good protocol. Next slide. So if I have to summarize, this is where I think the future is. We are going to go into perioperative chemo with IO. And once IO comes in, I think there's really no role for doing any radiation at all. Yes, we do have a data which says that after CTRT without pathological response, you can add immuno and improve your survival. So going forward, I think immuno in the preoperative with chemotherapy is the way to be going forward. Next slide. Next slide. So for me, this debate is been settled. It's as I have shown, perioperative chemo is the way to go for all G junction tumors. There's no doubt, just as there's no doubt that this gentleman is for me the greatest batsman of all time. Next slide. Thank you very much.
Thank you, Dr. Vamshi. So I think Dr. Hingorani, you are there. Can you just chip in and give your rebuttal?
Yeah, so I mean, I think the whole idea of this was to try and come up with the evidence for both possibilities. And I think, as I say, they both have a role in certain group of patients. I think what we can't ignore is that FLOT chemotherapy is a toxic regime. It has got grade 3 toxicity. Not everybody is suitable for FLOT. And in patients who have limited nodal involvement and limited length of disease, this may be a very toxic regime, maybe an over-treatment. We now have data from the Checkmate study as well. So we are using adjuvant nivolumab post-chemo-radiotherapy in patients who have residual disease. So they receive nivolumab for 12 cycles. And that actually showed a significant survival benefit for this group of patients. So there was a criticism about chemoradiotherapy not having optimum systemic treatment, but that's not the case anymore because we have randomized data about giving them adjuvant immunotherapy post if they have residual disease post chemoradiotherapy. And I think the important thing to understand is that if you look at the rates of R0 resection and the pathological complete response rates, I think the cross definitely showed a higher proportion of that, of both of them, which I think are important surrogate markers for overall survival. And the other thing to point out is one of the main other criticisms we have is that cross probably the survival benefit was due to reduction in local recurrence. That's not the case, actually. They published a paper subsequently where they showed that there was a reduction in the incidence of distant metastases as well. So basically, it is actually an effective regime, and it has got the high chance of inducing pathological complete response, high incidence of R0 resection, and has also been shown to reduce the risk of distant metastases. And combined with the adjuvant nivolumab, which is now approved, I think it is a very good protocol for a group of patients as long as you can deliver chemoradiotherapy, because you have to have a certain length of disease and the extension to the stomach has to be limited. Thank you.
Thank you. Dr. Vamshi, last 30 seconds for you. Any comments from your side, Vamshi? I think he's there, right? Off screen. Off link, right? Any questions from the house, Lord? Dr. Hingorani is there. Anybody? So thank you. Thank you, speakers. Thank you, Dr. Hingorani. Thank you, Dr. Vamshi. So we had a good discussion over there. And I think Dr. Vamshi spoke a bit about perioperative, which is not actually in the size of the motion for today's discussion. Well, that is one treatment option which needs to be considered. And as of today, we have both concurrent chemoradiotherapy and chemotherapy as neo-adjuvant setting, which are the standard of care. And I think meta-analysis done so far has also contradictory views. Few meta-analysis showed that neo-adjuvant chemoradiotherapy is better so far as survival is concerned. Another meta-analysis by the Peteli group, I think they with 18,000 patients, they showed that neo-adjuvant chemotherapy alone is a good option. So adaptive chemoradiotherapy can be a neo-adjuvant setting and option. I agree, Dr. Hingorani, and that is being also practiced in many centers, especially if the patients don't respond with upfront single chemotherapy. So those are the patients, they can be accepted for neo-adjuvant chemo-radiotherapy if they are progressing while on upfront chemotherapy. Thank you once again. Thank you.
Thank you, Prasenjit sir. Before concluding the session, may I request Dr. Ellen Biswas sir to present a memento to Prasenjit sir as a token of appreciation. Thank you, Dr. Hingorani, and thank you, Vamshi, for putting up such an excellent debate. We conclude our session here, and we'll be moving shortly to our next session, which is a talk on approach to a patient of liver-limited oligometastatic rectal cancer by Dr. Rachel Cooper. May I request Dr. Suchandana Goswami ma'am, radiation oncologist at Apollo Kolkata, to come over to chair the session and introduce the speaker. So I heard Rachel speaking about this topic first time back in 2016 when I was attending a course, FRCR Part 2A course at Tata Medical Center, Kolkata, and was thoroughly impressed by her presentation. And she has been my teacher, mentor, and guide while I was working in Leeds. Over to you, Suchanda ma'am.
Good evening, everyone. My task of introducing Dr. Rachel Cooper. She is the lead clinician for clinical oncology in Leeds Cancer Center, UK, and also the National Medical Director of Education and Training for the Royal College of Radiologists. Her area of interest is gynecological, colorectal, and anal canal cancers. Topic is approach to a patient or liver-limited oligometastatic rectal cancer. So I invite Dr. Cooper once again.
And thank you, Animesh and the organisers for inviting me to speak today. I will try and share my screen. I'm always not very good at that, but let's give it a go. And hopefully, has that come up?
Yes, ma'am.
Yeah, lovely. Thank you. So thank you yet again for that kind introduction. If my slides start to go a little bit slow, I'll just turn off my video. So yes, Animesh asked me to talk on this subject, and I did actually approach one of my colleagues, Natalie Casanova, I work very closely with, who's very much involved with the SABRE work, so I thought this might be an area of interest for her. So I'm presenting this really with their help as well from Natalie and Louise Murray, also at Leeds Cancer Centre. So liver-limited oligometastatic rectal cancer is quite an interesting area. And up to date, I think we've just been feeling our way and really treating these patients perhaps pragmatically and using experience rather than any evidence base. We still don't have a great deal of evidence base, but increasingly we can gain information from trials and work that's been done to point us in a direction which I think is a good approach for these patients, potentially curative, or if not curative, giving them a longer disease-free survival. So I think before we dive into how we might treat these patients, we should all be on the same page with regards to what we mean by oligometastasis. And I think that's really, really important. And why is that important? Because I think we're all talking about something different. And a very, very simple, broad definition would be the intermediate state between local regional disease and polymetastatic disease, so a limited number of metastases. And I would suggest, and this is a classification from Hellman, and you can see the reference there back in 1995, that there are 4 broad subtypes. There are synchronous, so that's presentation with the primary cancer, and we'll talk about that in more detail. Now, when we say synchronous, do we mean at the same time, at the time of diagnosis, or within a very limited period of time? And some people would define that within 6 months. So again, there's some controversy there. Metachronous would be the development of metastasis after the primary cancer has been diagnosed and probably successfully treated. But again, there's no standard definition of what that interval would be. Oligo recurrence is oligometastatic disease, which develops in the presence of a controlled primary cancer. And again, what would be the difference between that? And then finally, oligoprogression. And this is really a new concept, but it's a concept that I think we're all becoming more familiar with the increasing use of particularly immunotherapy and also biologicals, where we're tending to see control of the cancer with progression in maybe 1 or 2 different sites. And I'm seeing that quite a lot in gynecological cancers. And I think we will start to see it in rectal and colon cancer with increasing use of immunotherapy for those patients with dMMR. And so I think that's a really important area for us to start to think about how we might manage that oligo progression. So I've summarized these, or I've taken this diagram, and this was given to me by Louise Murray, just to emphasize this sort of progression between oligometastasis, oligorecurrence, through to widely metastatic disease. And we know that a high proportion of patients who have oligometastatic disease will go on to develop widely metastatic disease. And that's probably because they already had micrometastatic disease at the time, which clearly we were unable to detect. In fact, if you do look at the literature, there are about 9 separate clinical states that have been identified. And I personally feel that's a real overcomplication. But I've included the diagram for you here with the reference if you are particularly interested in doing this. But I prefer to stick to those 4 broad, fairly simple definitions. In the UK, how do we define it? Well, we often say less than 5 and certainly less than 3 would be defined as oligometastatic disease. And if you look at a more European approach, the Estro-Astras consensus statement from 2020, they came up with some very vague conclusions, really, if you do look at that paper. And there's no clinical data to support the maximum number of metastases or organs to define oligometastatic disease. But the consensus was it was somewhere between 1 and 5. So we've defined oligometastatic disease, hopefully, but we also now need to think about what might be resectability, because in terms of oligometastatic disease, we're still thinking about, can we cure this patient? And we know a high proportion of them we can go on to cure. And in most cases, we'll be thinking about surgery for these patients, so liver surgery. Now, I'm very lucky in Leeds because I work in a centre where we have extremely active liver surgeons with a large liver surgical department, hepatobiliary surgery department, who are very keen on resecting metastases. And I think the more metastases in the more challenging places, they seem to get more, shall I say, not say happy about, but I think they like the challenge. So I think it's important to say that the definition of resectability will depend very much on what you can access in terms of surgical expertise. You are aiming for an R0 resection. There is no point in trying to partially resect a liver metastasis because we know that with an R0 resection, and I'll show you some data in a moment, survival approaches anything between 20 and 45%. With an R1 resection or an R2 resection, it's no better than palliative chemotherapy. And of course, you put the patient through an unnecessary surgical complication with surgical procedure with potential complications. I think most surgeons would say that you need to leave about 30% of the liver or more. And again, resectability will depend on the number, the size, particularly the location, and the number of segments involved. Of 50%, as I said, will develop more widespread disease within 3 years. And that is because we obviously clearly not detecting the additional micrometastatic disease. There aren't really any randomized trials. So there are a lot of single case series, which I've put on here. Now you'll see some of these are for lung and adrenal, but the top section is particularly devoted to liver. And I think what you'll notice is that on the whole, the data is supporting a 5-year survival of around about 50%. And that's particularly for those larger studies and larger centres. So whilst we don't have any randomised data, the single centre expert centre data consistently comes up with a 5-year survival of about 50%. So I think we can be very we can be quite honest with our patients that that's the sort of prognosis they're looking at with oligometastatic disease. But again, it depends very much on the number of oligometastases, the biology of the disease, and the resectability of those metastases. So clearly, that's a little bit, the surgery is a little bit beyond what happens when those patients arrive in our clinic. So we see patients who present with both a synchronous primary rectal cancer and synchronous oligometastatic disease, however we define that. And that will probably depend on whether the liver surgeons say they can resect the disease with an R0 resection. So how do we approach this group of patients? Well, I think we have to think about this very logically and think about both the primary and also the metastases. So I like to divide them up into 3 broad groups. There is a 4th group, but that's the group with really where we've got essentially unresectable, either rectal or liver disease, which we'll talk about separately. So we have a very rare situation, perhaps, where we have a primary with metastases, which are deemed resectable, but the primary has no high-risk features. When I talk about high-risk features, we're talking here about any nodal involvement, any extramural vascular invasion, or involvement of the potential circumferential resection margin or the mesorectal fascia. I think this is an extremely rare situation. And in that situation, you could potentially offer surgery to both the primary and the metastases, either synchronous or staged, and then go on to give adjuvant chemotherapy. And that would avoid radiotherapy in these patients where they don't need any radiotherapy for the primary. In reality, I think a lot of people would still consider total neoadjuvant treatment. And I can see that you're having a debate about that a little bit later on in the programme. So I've just tried to avoid that, a long discussion on that, but I'm going to come to that in a moment in relation to the next section. So for this group of patients with very early rectal cancer, no high-risk features, but resectable metastases, there may be a good argument to avoid radiotherapy completely, go straight to surgery for both sites, and then think about the addition of adjuvant chemotherapy, as you might do with, say, colon cancer. But I'd emphasize that's a very rare situation. I think this is the most common situation where we have a primary, which is deemed resectable, but does have high-risk features. So again, just to remind you, those high-risk features would be extensive T stage, so T3B and beyond, nodal involvement, extramural vascular invasion, or the circumferential resection margin or mesorectal fascia, either involved or threatened, i.e. within 1 millimeter of the mesorectal fascia. In this situation, you know that you want to give some neoadjuvant treatment to both the primary and before you go on to treat before you go on to give for the patient to have surgery, sorry. And it's really a question of how do you integrate that neoadjuvant treatment into a situation where you know you've already got metastatic disease and you don't want to risk the progression of disease within the liver. Clearly, chemo-radiotherapy is an option, but the issue I have with chemo-radiotherapy is that gap between finishing your chemotherapy and then going on to surgery for the primary, where the patient is essentially untreated. And you could argue for the whole of that time they're untreated, because the chemotherapy that we give concurrently with radiotherapy in that situation is of a lower dose, whether you use 5-FU or capecitabine, is of a lower dose than you would give as a systemic anti-cancer treatment. So I think that is something to think about very carefully. I think a much better alternative is to give short course radiotherapy, which we tend to use more in the north of England and Northern Europe. And then between the short course radiotherapy having the action on the primary tumour, so shrinking the primary tumour down to enable an R0 resection by the surgeon, you've got a gap in which you can offer neoadjuvant chemotherapy. And that will continue to treat the primary. And then following reassessment with CT and MRI, hopefully to go on to surgery either as a primary to the primary metastasis synchronously or as a staged procedure. I've put any role for adjuvant chemotherapy, and I'm just going to turn my camera off because it's telling me my internet's a bit unstable. Any role for adjuvant chemotherapy, because we know that adjuvant chemotherapy in the setting of rectal cancer, having received some form of neoadjuvant chemotherapy, the data suggests that the benefit is very minimal. Now, this was a plan or a protocol that we use very much, particularly in Leeds, and as there are a lot of centres in the north of England, without much evidence to back it up. But we now know that there is some good evidence to suggest that this is a good treatment with improved outcomes for patients with high-risk rectal cancer. And that data comes from the most recent randomized trials in total neoadjuvant treatment and the Rapido. So the Rapido study randomized patients between chemo-radiotherapy, followed by surgery, followed by adjuvant chemotherapy, or putting all of the treatment up front, short course radiotherapy, followed by chemotherapy, followed by surgery. So the experimental arm, which we know has shown to be improved outcome, would be the arm that we would suggest you would use in the situation of patients with oligometastatic disease. And so the protocols that we've been following, the evidence is really starting to catch up a little bit to suggest that this is a good protocol for patients, with evidence to suggest that this may improve outcome. And you'll notice in the experimental arm, all of the chemotherapy is up front, so they don't get any adjuvant chemotherapy. And that's why I would suggest that we don't need to use adjuvant chemotherapy. There's no evidence to use it in this setting. The other interesting point about Rapido is that it was a well-tolerated treatment. And patients, whilst they experienced a little bit more increased toxicity in the experimental arm, most patients went on to get surgery as planned, with no difference in surgical morbidity. And you can see that there. So that's the situation for patients where the disease is resectable, both primary and metastatic, albeit that there may be some high-risk features in the primary, in the rectal cancer. But what about the situation where you have borderline resectability, either in the primary or in the metastases? And that's often more likely in the metastases. So in this situation, particularly if you have a young patient, good performance status and no comorbidity, you might want to think about putting a more intensive chemotherapy regimen at the beginning of their treatment. Now, there are a number of ways that you could consider doing this. And you could consider short course followed by IR-MDG, so 3-drug combination, which is not something that we have tended to do in the past. But we now know that there are some data to point us in a direction of giving more intensive treatment for these patients up front. And that evidence is coming from the PREDIGE 23 trial. So the PREDIGE 2023 trial has reported at a very similar time to the Rapido trial. And again, whilst it's not looking at the oligometastatic setting, we can draw some conclusions from this trial to support how we treat these patients with very limited metastatic disease, whereas I emphasize, we're still aiming for cure. So in this situation, as you will see, the experimental arm, which is the lower one highlighted in red, intensified the chemotherapy. So patients received triple therapy regime, it was 6 cycles over 3 months, followed by chemo-radiotherapy with a break of 7 weeks, surgery, and then in addition to that, adjuvant chemotherapy. And that was randomized, as I'm sure all of you are aware, against standard chemo-radiotherapy, surgery, and then adjuvant chemotherapy. So it was the addition of the 3-drug combination intensification up front, which was the real key to this. And we know that the data from this trial, as with Rapido, has shown an improvement in outcome as well. So we know that for these patients with no metastatic disease, but high-risk features, rectal cancers, there is evidence to suggest that giving them total neoadjuvant treatment is of benefit. And we can say probably that we now have a regime that we could use in the situation where we have a patient with borderline resectable disease, good performance status, no comorbidity, who would tolerate this treatment. I have to say, having given patients both Prodigy 23 protocol and the Rapido protocol, the latter, the Rapido protocol, is much better tolerated, even in patients who are really young, fit, with no other comorbidity. So I think giving the 3-drug regime up front is something to think about very, very carefully in terms of the patient's performance status. However, for those patients who've got borderline resectable disease, it's really a good alternative to be considering. And again, the report suggested that this treatment, the experimental arm, was pretty well tolerated. So I think we have now some protocols of how to approach synchronous metastatic disease in the rectal cancer setting. We can also think about what evidence we have from the colon cancer setting to suggest that giving chemotherapy up front is of benefit. And we know that the EROTC 40983 study randomized patients between preoperative FOLFOX and postoperative FOLFOX, and they showed an improvement in progression-free survival of about 7 to 8%, but no benefit in overall survival. Now, I think what this trial is telling us that whilst giving upfront chemotherapy, and this is, as I say, in colon cancer, may not improve overall survival, we're not doing our patients any harm. So what I wanted to emphasize is that idea of giving the short course and then neoadjuvant treatment in the oligometastatic setting is certainly not leading to those patients having progressive disease in the liver during that period of time that you're giving them neoadjuvant treatment. And I would mention that the EPOC study, as I'm sure all of you are aware, in resectable disease showed a worse progression-free survival for those patients who received cetuximab and were KRAS wild type. In addition, anecdotal evidence and now some increasing evidence from phase 3 trials suggests that the 3-drug regime, you can get the maximum effect in terms of shrinkage and control of the disease within the liver, leading on to potential resection. So again, if we draw on trials not necessarily directed at oligometastatic disease, we can use that evidence to really justify or at least confirm the protocols that we're using for these patients, more to ensure that we're not doing them any harm, as opposed to trying to justify any benefit from that. And that was just to suggest if you do have synchronous metastatic disease which is not resectable, then clearly those patients need to go down a primary chemotherapy route. In terms of the non-synchronous, how do we manage those patients? And this, I'm talking about rectal cancer, but we have very little data from rectal cancer. So again, we must go back to the colon cancer data in particular. And for most people would say that if a patient who's been treated successfully for their rectal cancer and then develops a liver-only metastatic disease, really the primary treatment would be surgery. So you'd be looking at trying to resect those metastases. If it was borderline resectable, then again, you'd want to consider some neoadjuvant treatment as you would do with colon cancer. What about the role of adjuvant chemotherapy then in that setting? If they've not received any previous adjuvant chemotherapy, and I think that will be a very, very small group of patients, certainly it would be something to consider. If the metastasis develop within 1 to 2 years and practice varies and there is no definite evidence to point you in one direction, most people would not consider further adjuvant chemotherapy. Beyond 24 months, which is quite an unusual situation, you might want to consider it. And in those patients, you may want to give a further neoadjuvant treatment prior to their liver resection. We also need to now consider the implications of DMMR. So we know that about 15% of patients have a deficiency in the MMR. And most of those are sporadic, a small number are germline. Most of those occur in the MLH1, PMS2, but we do see smatterings of other the losses of the MMR proteins. We also know there's an interaction with BRAF, and they have a poorer prognosis, and they can also indicate whether this is most likely to be sporadic or germline. But this is really important to know because we know that data from preoperative chemotherapy from the Foxtrot study that was in locally advanced colon cancer, for those patients who did have a deficiency in their MMR, they didn't respond to neoadjuvant treatment. So we really need to think about this in rectal cancer as well. So for those patients who have deficiency in their MMR proteins with oligometastatic disease, where we might normally be considering some form of chemotherapy, we know that they're unlikely to respond. And in that situation, we're either thinking about giving them radiotherapy alone and then going on to surgery for both the primary and the liver if both are resectable, or we may want to start considering immunotherapy. I think this is a very, very grey area, but there are some data, as I'm sure all of you are aware, that are coming out to suggest that this may be a treatment for these patients. However, the duration of treatment and when you would want to introduce surgery is still something that's very much in the air. And I'm not going to go into this in any detail, but I think it's something that you need to be aware of. And we certainly should be testing our patients for their MMR status before considering neoadjuvant treatment. Just a final note on surgery, when to do surgery. We know that surgery is usually done about 4 to 6 weeks after their last cycle of chemotherapy. So you need to coordinate very carefully with your liver surgeon, particularly if you're not in the same centre. The data suggests there's no point in continuing chemotherapy beyond the point of resectability, as you just increase the likelihood of liver toxicity. And oxaliplatin and irinotecan have different toxicities in the liver. Data suggests about 10% of patients will progress on neoadjuvant treatment within the liver. So what are the alternatives to liver surgery? And in the last sort of 5 minutes, I just wanted to talk about these. In the UK, we have radiofrequency ablation. I'm not sure whether you have access to that from your centre. This is NICE approved, as is microwave ablation, but that's much more rarely used. It's reserved for those patients who are not fit for surgery or have very difficultly placed tumours with relation to surgery, often in a recurrence following surgery, which is difficult for further operation, or sometimes an adjunct to resection. So if they're a very small volume disease, which the surgeons can't resect completely. In terms of efficacy, recurrence rates are higher than those reported in surgery, but that might reflect the group of patients that are treated with RFA compared to surgery, i.e. they're a poorer prognostic group. Tends to be about 10% less. And there's a little bit of evidence to support the use of systemic anti-cancer therapy with RFA in the same way as I've been discussing in the surgical situation. There has been an attempt at one trial. This was a phase 2 study. It was a little bit of a messy trial, and it was actually stopped early due to poor recruitment. However, the data from that does suggest that there may be some benefit from the addition of liver-directed treatment, and that would be RFA in the main, although some of those patients also went on to get additional treatment, particularly surgery or SABR, for those patients with oligometastatic disease. But as I say, this was a small study and it was stopped early, and you can see the data at 5 years is relatively low patient numbers. What about SIRT? So that's selective internal radiation therapy. This is NICE approved in very, very limited settings. So there's been a trial in this, the Foxfire global study. And this was patients who were chemo naive. They had non-curative liver metastases. They received chemotherapy plus or minus SIRT. And there was a better response rate in the liver and longer progression-free survival, but no improvement in overall survival. So SIRT really is reserved as a third-line treatment and has no real place in the treatment of patients with oligometastatic disease that is potentially curable. And then finally, I wanted to mention SABR. Now, again, I can see that you've got Ganesh coming to have a debate with you, which I think will be great fun on SABR. And this is where Natalie and Louise have helped, because I don't actually do the SABR treatment. It's very specialised in our centre to a small number of consultants. But we know that SABR does have a role in the treatment of metastatic disease to the liver, and in particular, oligometastatic disease. Again, how do we define it? So it's going back to the slide that I showed you earlier, and we would tend to define it as 3 or less metastases if we were considering SABR for these patients. And clearly, most of these patients will be patients who, for whatever reason, have been rejected in terms of surgery, or surgery is not felt to be appropriate. So the rationale for SABR, as you're all aware of, is that prolonged survival has been observed in a proportion of patients receiving surgical treatments, both in the lung and the liver. And as I showed you earlier, that's around about 40%. So we think that a radical treatment may result in improved or prolonged disease control or survival. And as SABR can achieve a radical treatment to oligometastatic disease, as with surgery, we'd expect an improvement in outcome for these patients. We have very little data in terms of randomized trials. There are increasingly single center trials which suggest that there is an improvement in outcome for patients who receive SABR. But the SABR COMET study, which was a randomized phase 2 study, and that was in multiple cancers, so this was just not colorectal, and this was looking at SABR in a maximum of 3 organs with a total of 5 oligometastases, which were all amenable to treatment with SABR. And if you try and glean from this some evidence for its benefit in colorectal cancer, you can see that in the SABR group, there was about 14% of the total trial population had colorectal cancer, and about 13% were in the liver, but that is from all tumor sites. And they were mainly bone and lung. But what they did show that there was an improvement in local control with a median follow-up of 51 months. And there was some suggestion, both in overall survival and progression-free survival, that SABR, certainly in a mixed oligometastatic setting, played a role in treating these patients. So certainly for those patients with rectal cancer, particularly where the primary has been treated and resected, but for whatever reason, surgery is no longer appropriate for the liver disease, then there may be a role for considering SABR. And that was just to emphasize the results from this study. So really, to just put all that together, for those patients who've got resectable disease, both in the primary, the rectal cancer, and in the metastases, we would consider the resectability of those, and we'd be thinking about treating the primary and the metastases. And that would be a combination of radiotherapy or chemotherapy and some form of neoadjuvant chemotherapy. For metachronous disease, then we suggest that we treat these very similarly as we would do with colon cancer. And for those patients who've got unresectable metastases, we now know that there are a number of alternative treatments, with probably SABR and RFA being the most important and showing the most promise for these patients. And thank you very much.
Thank you, Dr. Cooper, for taking us through the whole spectrum of the disease and to touch each and every point that we need some clarification. Thank you so much.
It's a
In
pleasure.
spite of that, if someone has some questions, you may clarify.
Thank you, Rachel. Thank you for the excellent presentation. So I have a question. I know you do not do biological therapy, but having said that, so you mentioned about for resectable disease, whether it's primary or metastasis, role of biologicals, whether it's EGFR antibody or VEGF antibody, it's probably defined that it is not beneficial. But for borderline resectable patient, where you're uncertain about whether the patient would eventually become fit for curative intent treatment, whether you would refer the patient to medical oncologists for additional biological therapy on the top of chemotherapy?
Yeah, certainly. We know that the evidence for bevacizumab is probably less, but certainly the evidence for the wild type KRAS patients, for cetuximab or similar there are data now to show that these patients should be considered for that. So definitely, Animesh, in the borderline resectable situation, we would be considering that for those patients because there's a high chance they may eventually go down the palliative route. So in that setting, you would want to give them perhaps the most effective palliative chemotherapy treatment up front. And then if they do become resectable, then clearly you would refer them on for resection. So yeah, that's an excellent question and a really, really good point to make.
Another question, Rachel, I'd like to ask, in a resectable liver metastasis, in an oligometastatic setting, in a resectable liver metastasis, would you offer patient saber over surgery? Is there any patient group would you choose giving the option of saver over surgery?
Yeah, so I think that's a really good question. And I think in the UK, as you know, Animesh, our hands are a little bit tied in terms of when we can offer saber. So patients presenting with synchronous disease, it's more difficult to offer saber. I think one, because of the evidence that we have to date, and two, just because of our setting. I guess though, I think over time, the data is going to come out to show that for some patients, yes, with limited, however you want to define that, as I said, and I think that is really the next step for me, not being an expert in saber, but looking at it. I think the community really needs to come together and make some clear definitions of what they mean. But for very limited disease, personally, I think saber is a great treatment. We have the equipment sitting there. It's a lot cheaper than surgery. Patients don't have to go through a surgical procedure. So yeah, clearly I'm a massive fan of radiation oncology. That's why I do the specialty. But I think that, gradually that will what we think is the right thing to do will catch up with the evidence and what we're able to do.
I think we have got one question in the chat box. Can we have that question open up? So we've got a question from Dr. Nikhil Gopi. In synchronous oligometastatic setting, how is the ideal sequencing of primary and metastasis directed local therapy? I think I'll explain that.
Yeah. I mean, I personally, so really, pragmatically, we used to give radiotherapy, and then in that period where you're waiting for the radiotherapy to work, we give the chemotherapy. Now that was just a pragmatic, eminence-based approach. There was no real evidence for it. But nicely now, Rapido and Prodigy have actually justified and verified what we've been doing for some time. And I think there are lots of questions. I think it's a really good question because I think there are still lots of questions in the air about this. Because if you look at Rapido, it is 18 weeks of chemotherapy, but most of the UK are actually giving 4, so they're giving six months. We're giving 3 months, so 4 cycles based on the ideal data. But the ideal data is saying that 3 months of chemotherapy for the majority of patients, and I would say all patients, is as good as 6 months. So we've shortened that time, but does shortening that time give less time for resolution of the primary tumor? Is that really important in trying to get, say, a complete response? And then you may actually be able to avoid surgery in the primary. So I can't go into everything. I feel very strongly about this. So I'd happily come back and debate this because I think that I think there are still lots and lots of questions to answer about total neoadjuvant treatment. But from an overall point of view, I think that's the way to go. Radiotherapy first and then chemotherapy. And for a small group of patients with really advanced disease, I think giving the triple therapy up front is probably the right way to go.
So we'll conclude the session. Thank you. Thank you very much, Rachel.
Thank you very much. And I've seen Ganesh has been on, so please, apologies, Ganesh, for my saber bit.
Okay. So
bye. Have a good conference.
Before we move on to our next session, I request Dr. Ellen Biswas sir to hand over a memento to Suchanda ma'am as a token of appreciation. Thank you. So we are running a bit late. in our session. So we'll be moving on to our next session quickly. It's a very important panel discussion. May I request our chairperson, Dr. Shubhadeep Chakraborty, surgical oncologist, and Dr. Ellen Bishwas, sir, radiation oncologist, to come to the to come to the stage for chairing the session. May I request Dr. Shuparna ma'am also to join the session. Over to you, sir.
So now starts the panel discussion on one of the hotly debated and most extensively discussed topic in the recent times, and that is neo-adjuvant therapy in rectal cancer. This is a panel discussion, and my duty is to introduce the moderator. The moderator of the discussion is Dr. Parth Desai, who is a clinical oncologist at Royal Preston Hospital in UK. He has been trained in Christie Hospital, Manchester, and with special interest in breast and colorectal cancer. So I think my colleague, Dr. He will introduce the panelists.
Good afternoon. It is my honor to invite for the panel discussion on neo-adjuvant therapy in rectal cancer, Dr. Samima Islam, Dr. Shogat Podwal, Dr. Arvind Kumar, Dr. Amitabh Ray, Dr. Manu Prasad, Dr. Kaushik Bhattacharya, Dr. Trinanjan Basu, Dr. Nikhil Agarwal, and Dr. Anish Bandyopadhyay. So with the permission for all the chairperson, we can start. I will request Dr. Parth Desai to start.
Hello, good afternoon for India time and still morning here. And thank you, Animesh, for inviting me. It feels quite humbling to speak in presence of three of my teachers. Dr. Cooper, thank you for all your leads courses for our FRCR exams. Dr. Radhakrishna, I would not try to say anything about Saber, I promise that. And Dr. Dattwari, I read your name somewhere, but I can't see you, but my best regards and wishes for you for New Year. What I have here is sorry, Animesh, how do I move the slides? Thank you very much. So it is just about deciding what is the new standard of care for rectal cancer patients. What we have seen recently is that at least in UK here, there are loads of patients who are stoma averse, and we now have new trials, and Dr. Cooper has already covered Prodigy 23. She has covered the other trials. But essentially the question remains like, how do we go about it? The standard short course radiotherapy, long course chemo-radiotherapy, short course radiotherapy, and then wait and watch for patients who are quite elderly or of poor PS. And we have come a long way going from 90s trial where the surgery was the only option and the local recurrence rate was as high as 46%. And then the Dutch trials from early 2000s where surgery and a standard TME, total mesorectal excision, we started to achieve a local recurrence rate of just 5.8%. So we have come already a long way in terms of managing rectal cancers. Can I have the next slide, please? So ultimately, this is what we do in general. We are guided by the pelvic MRI and we consider what is the risk of local recurrence. I'm sure the panel as well as the audience already know about this, but it is essentially the risk factors that we look at about trying to achieve a good surgical resection. R0 resection is our ultimate aim. T3 disease, not necessarily unless it is more like T3C or T4, low rectal cancers where it is almost touching the levators and you are considering possible ending up with a stoma for life, vascular invasion or high lymph node burden. And based on that, we can divide them in the three categories. Either they go straight to surgery or short course and then surgery, or long course chemotherapy and surgery. This has been the standard of care for a few years now. Can I have the next slide, please? So this is what we do in general at most of the centers. Short course radiotherapy, 25 fractions. And we do see that about 5 to 10% of these patients, especially the low stage ones, do get pathological complete response with this alone. For long course chemoradiotherapy, the pathological complete response is slightly higher. I would just mention here that for my center, we do capecitabine on the days of radiotherapy. And I understand that Christie and possibly Clatterbridge does it for all throughout the treatment. New concept emerging is long course chemoradiotherapy with boost to the lymph nodes, where we are going as high as up to 54 gray in 30 fractions. Ultimate aim remains that of pathological complete response with these ideas so far. Can I have the next slide, please? The new aims that we are now talking about is what is the quality of life, organ preservation, and avoiding stoma. Quite a few of the patients are coming to clinic who are in their 60s or 70s, and they absolutely don't like stoma. Quality of life is important because for us, when we say that, well, you might end up with a long-term toxicity of grade 2 diarrhea, it sounds like a simple thing to us, but living with diarrhea where they constantly have to be on the lookout for a loo is not exactly a good quality of life. And organ preservation, as it has been heavily discussed in cancers like bladder cancer as well. Next slide, please. Dr. Cooper has already covered most of the things, but I will just highlight on the main things that 2015 onwards, we have had multiple trials which has looked at total neoadjuvant treatment in the form of giving long course chemoradiotherapy and some additional chemotherapy before we proceed to surgery. The standard of care, we are achieving about 15% pathological complete response, especially for lower stages with long course chemoradiotherapy alone. The debate is on the extent of how far do we push it, long course chemoradiotherapy, and then how much of chemo is better. And we are looking at what is our ultimate aim. Is it pathological complete response versus disease-free survival? And more importantly, if we can achieve a disease-free survival of anywhere between 40 to 80% over a period of 3 years, that is also meaning that the patients are living for 3 years without the need of surgery. Can I have the next slide, please? So Rapido trial back in ASCO 2020 suggested that short course and then 9 rounds of FOLFOX achieved pathological complete response of 28%, but again, this was doubling the grade 3 toxicities. Stellar in JCO in 2022 suggested short course, 4 rounds of Capox, and then it did achieve a good overall survival. It increased by about 15%. Polish 2 trial suggested short course and FOLFOX, again, quite similar to Rapido. All of these trials are definitely at high risk of grade 3 toxicity, which is almost double for most of these patients. Next slide, please. So Rapido trial is what is, Dr. Cooper has already said this, but this is what we are standardly following because patients tend to tolerate it relatively better. And we do achieve a better disease-free survival at 3 years. Although there is no clear difference in R0 resection between the short course versus long course in a total neoadjuvant setting. Next slide, please. Now, Rapido versus Prodige 23, this is the ultimate debate. Rapido has been found to be better for disease-related treatment failure, chances are better. Prodige is better for disease-free survival. There is no difference in overall survival, and long course chemoradiotherapy is better for local relapse, but OS, overall survival, is not statistically significant. Next slide, please. Ultimately, when we have all these trials, we are looking at what is the best course of action in that case. And I think the patient selection ultimately is the most important thing. I've got about 6 patients on TNT treatment right now, but they are between the age of 30 to 50 with a performance status of 0, and they are very fit people. And somehow it is the oxaliplatin that worries me more. They start to fall apart after 4 or 5 rounds of treatment. Long course chemoradiotherapy, followed by chemo, followed by surgery, we are achieving much higher clinical complete response rates, and that is better for patients who are quite stoma averse. And at present, we are basically following short course radiotherapy, followed by 9 weeks of FOLFOX, which is my particular preference instead of Capox, and then followed by surgery versus observation. Next slide, please. We don't know what is ideal. I think based on fitness, age, comorbidities, I think that question remains open to all. Short course and delay remains an important choice, especially as we saw in Stockholm 3. Hi, can you hear me?
Hello.
Sorry.
Can you hear me? Yeah, Dr.
I can hear you. Sorry.
Yeah, Dr. Desai, there are a lot of panelists waiting, so we would suggest that you ask, involve them in the panel discussion also.
Absolutely,
It's a
absolutely. I've got about 2 more slides and that is done, so it is open for discussion. Yeah. And long course chemoradiotherapy for relatively unfit patients, and it is ultimately the discussion between consultant and patient. Next slide, please. Dr. Cooper already mentioned that. What happens to the patients who achieve clinical complete response? What do we do with them? And we do have encore study from Northwest by Professor Renahan. And in that, 80% of the patients didn't recur at 3 years. And even when they did recur, they were still solvable. So stoma and quality of life remains a big factor for patients' decision in these cases. Next one. Surveillance, it depends on what is available at the local center and what the patients are willing to pay. Next one, please. Currently under investigations are multiple other things, but I think Dr. Cooper has already touched on most of these topics, and I would leave it for the panel to discuss. Animesh, I'm happy to conclude here, and I would prefer if we can carry on conversation more openly. Sorry, Animesh, can't hear you.
Can you hear me now?
Yes, we can.
Parth, it was supposed to be a panel discussion, and there are a lot of panelists over there.
I'm so sorry. I just thought I would give a brief outline. Dr. Cooper had already covered it, and this is just what we have so far, and I would be much more guided by the panelists now.
I would request you to ask questions to the panelists regarding
Of
their.
course. Of course. So in terms of the panel members, can you please share what is the local practice that you follow and what rationale do you discuss with your patients?
Can you hear me? In our practice, especially in parts of Bihar where I practice, the rectal cancer is more common in the younger patients, 25, 30, 20 years. We have patients in this age group. So I generally follow the PRODIGE 23 TNT with modified for Frenox. These are the younger patients, they tolerate, and their disease biology is very bad. Means high-grade tumor, poorly differentiated rectal cancer we have commonly. So in my routine practice, I follow the PRODIGE 23.
In those patients, sir, do you also do repeated CT scans intermittently just to make sure that the disease has not gone metastatic in the meantime?
I often do, but not as a routine practice routinely.
In terms of PRODIGE versus Rapido, do you have any particular preference for any specific other reason? Your population is young and fit, which is fantastic.
Yeah.
But you consider Rapido for any other specific group of patients?
Rapido, yeah, for those group of patients, means actually see the radiotherapy dates, some constraints are there. So
sorry, Dr. Kumar, I don't think I can hear you, but
yeah, can you hear me right now? Hello, can you hear me? Hello.
Yes, sir, we can hear you, sir.
Yeah. I just want to make my point that another reason for me for going for PRODIGE is that meanwhile, while the patient is on chemotherapy, the radiation dates are so prolonged that my patients they don't get their dates delayed, because if I go for Rapido, then if I have to wait for another 2 to 3 weeks for radiation to start.
Of course.
So, Dr. Parth, like here, obviously, rectal cancer treatment is very much individualized. And as we discussed, these TNT protocols are not for each and every patient, especially the patients who are old and who are not very fit. So obviously the standard of care had been long course chemoradiation, and some of the patients will be fit for that. Now, specifically coming to Prodige versus say Rapido, right? So Rapido is one of my favorite protocols, actually, if the patient can tolerate, because the treatment duration is short and stoma duration is shorter, right? And we can quickly do away with the treatment, slightly higher toxicity, but tolerable. Now, specifically a patient where there is a contraindication for short course chemoradiation. Say, for an example, sometimes we see a patient where the disease extends from rectosigmoid junction to lower rectal cancer, or there is so much rectal, sphincter involvement that my radiation oncologist will say that I cannot give short course radiation because I will want to radiate the inguinal region as well. And there are some more contraindications for short course, which radiation oncologist will enumerate more right upon. So in those patients, I would want to do Prodige 23 in a fit patient. And one more subgroup of patient where I would be more happy to do Prodige 23, where I find the patient more at high risk of systemic failure, right? Say, for an example, if there are nodes along the IMA, right? So I see these patients at a high rate, and though in in Rapido, we can start chemotherapy after say around 3 weeks, but we get one higher, more effective chemotherapy in Prodige 23 by giving FOLFIRINOX, and 2 we can quickly start it. So these are the group of patients probably where I would want Prodige 23 compared to Rapido.
Thank you, Dr. Agarwal. Dr. Islam, would you like to comment?
Actually, regarding choosing of short course or long course radiotherapy, actually, I go for considering some factors, that is the patient-related factor, if the patient age, performance status, and the comorbidities, and also the patient choice. And for the tumor-related factor, I consider the tumor bulk and the extent of nodal disease. And institutional factor, actually, I go for the experiences and for the pandemic condition. So most of the time, actually, we prefer the Prodige 23 trial. We go for the long course radiotherapy in that case, actually.
And whether you choose Rapido or Prodige 23, any form of TNT, do you find most of the patient managing to complete the standard protocol?
Yeah, I think so. Actually, Prodige 23, we go for the long course radiotherapy. We go the 50.4 radiotherapy in 28 fraction. And after that, we previously go for the chemotherapy and then complete the total neo-adjuvant treatment, and then assess the patient with the MRI of lower abdomen, either if there are any complete or partial response over there, and then go for the surgical
because
option.
that remained one of the concerns with all these TNT treatments. Like MAGIC trial for gastric cancer was fantastic, FLOT for esophageal is fantastic, but ultimately it comes down to how many patients do actually manage to complete the whole treatment.
Actually, it's a matter of time. Actually, we are previously we just treat the locally advanced cancer patient, rectal cancer patient, with the neo-adjuvant chemo-radiotherapy followed by surgery, and then according to the histopathological reports, we go for the adjuvant chemotherapy. But very recently, we just shifted after that Prodige 23 and Rapido trial, we just shifted to that total neo-adjuvant treatment. So actually, the overall response, we cannot, we are just following that patient in a very short duration of time. So right now, actually, I cannot conclude about the complete scenario, but I think it will take some time to get the proper outcome of that treatment.
Okay,
I think we also got Dr. Shogat from Nepal, Dr. Manu Prasad, Dr. Triranjit
Yeah,
Bashu, and
I'm
Dr.
sorry, I
Anish
can't
Bhagwat.
see the other gentleman on the line here or on the video. Please speak up,
Hello.
sir.
Yeah, I'm Dr. Manu Prasad. Actually, I practice in a center in South India. So we also follow something like a rapido protocol. So most of our patients get short course RT and then Capox-based chemotherapy. And in select patients, as the previous panelist has already discussed, those who had a bulky disease, in the locally advanced disease, probably they'll go for concurrent chemoradiation. And regarding the Prodigy 2 strategy, that is very reserved for a few patients who do not respond well to the concurrent chemoradiation. So only in those patients we go for a triple drug regimen. Otherwise, we generally follow the rapido protocol. So this is our practice.
So hi, I'm Dr. Basu. I'm from Mumbai. I'm a radiation oncologist. So for our, so finally it remains, of course, you have to discuss with medonc and the surgeon, because the surgeon roles is very important, what they're trying to do. And you really need to tell your patients as well, whether they're opting for a TNT proper or they should be aware of the risk, because there are logistic challenge to it. If you have to keep a patient really on TNT, the investigations goes at times too much for the patient. Another challenge in a diverse scenario in India is many a times people after their first or second, say the scopies and the MRI coming well, they tend to drop off in follow-up, which is a very risky thing to happen in a TNT approach, because there will be chance of local regrowth. So that one needs to understand very well. In our center, the Rapido is quite famous. So as radiation oncologist, where I would not maybe force for Rapido, like for short course. So we do short course with definitely IMRT. There are UK guidelines now to follow for bowel and bladder constraints. So one needs to really follow that doing. Personally, I feel though 25 in 5 is less, people are trying to explore 13 5 now, because if you calculate EQD2, you're really not achieving a very high dose in 25 in 5 compared to doing a 15, 25, or even trying to do a lateral pelvic nodal boost. So yes, where we need to treat the inguinals, where the disease coming to the low rectum involving anal canal or a lateral pelvic node, we would try and refrain doing a short course, try to put for long course them. Otherwise, Rapido is a good protocol. It's quite well tolerated, and especially for mid to upper rectum with bad biology like signet, young age, it's good to complete the short course because their local symptoms settle well and then send for the chemo, because eventually that is what is required in them, because they'll have more systemic failure than local.
When we have, I think we have a medical oncologist in the panel as well. Sir, do you have any opinion on these MSI high group of patients?
I think Dr. Arvind Kumar and Dr. Manu Prasad are medical oncologists. Can ask them the question.
We did not actually get the answer from the panelist to that question put by Dr. Desai. What proportion of patients can actually complete the protocol, Rapido protocol, or what proportion of patients?
I would like to answer this question. Myself, Dr. Anish, I'm working in a government medical college, and we are doing Rapido quite regularly, and I can say about 80 to 90% complete them quite safely and quite comfortably. They complete it, and we are getting very good. It's part of a study. We are getting very good response, PCRs. So it is well tolerated, Rapido.
And within that, sir, do you have a particular preference of using Capox versus Folfox?
We prefer Capox because it's logistically superior, and it is 6 cycles of Capox. We prefer that. Folfox, you need admission, and Capox we can give it in daycare, so we prefer the Capox.
And do you come across many patients who essentially ask for this type of treatment or TNT in the name of organ preservation, or who don't want stoma, or is it not so common for your practice?
See, the type of patients we see and the setup we have, we actually get patients who already have a stoma, emergency stoma done before neo-adjuvant therapy. And patients would love to have a stoma-free, disease-free survival. We don't opt for organ preservation routinely for, say, suppose an elderly patient, a patient who is not willing for surgery, we at times go for that. And otherwise, it's not a routine.
Dr.
Hello,
Paudia,
Dr.
sorry,
Anish.
sorry.
Dr. Anish,
Yeah.
you told that you prefer a rapido trial and you practice it in the hospital, but you give capox 6 cycles with short course radiotherapy. That is actually not the rapido trial, isn't it?
Rapido had both the things, capox and Folfox.
I think we also got Dr. Shogat Podial from Nepal. Can we ask Dr. Shogat to give his views about the practice that they follow in Nepal?
Yeah, thank you, Dr. Animesh. Hello. Hello, am I audible?
Yes, you're audible.
Okay. So actually, I work in a government setup here in Nepal. So in fact, there are problems with the radiotherapy dates with us. So although I'd like to practice with the Rapido, but there's been a due to the waiting time, it's quite impossible. So we do practice for fit patients the PRODIS kind of protocol. We start with chemotherapy, followed by take a date for the long course chemo-RT, then go for surgery in such cases.
Thank you, sir. I see a hand raised by Dr. Mohan Hingorani.
Yeah, hi, sorry. Yeah, I'm not part of the panel actually, but I just wanted to express my views. So I'm a clinical oncologist, I think, in UK and in Hull. So we have actually spent a lot of time trying to develop some guidelines for with all these TNT protocols coming in. So we kind of got together, I think it was Leeds, Sheffield, and Hull. So what we felt was our experience is that I think TNT protocols are pretty effective, but we have to understand that they have a role mainly in patients with T4 and N2 disease. That's where the real benefit is seen. But you have a locally advanced group of rectal cancers who don't have T4 and N2 disease. And basically that's where, because I think what's happening is that with the locally advanced rectal cancer, means with these TNT evidence coming through, I think we are kind of as default adopting TNT protocols. We can't get away from the fact that these are toxic regimes. And PRODIS is actually pretty toxic, and a lot of patients with rectal cancer in our centers are elderly who can't have PRODIS. So our TNT default option is actually Rapido. But having said that, there's still a group of patients who have, say, T3B or T3C disease, where you would probably consider some form of neoadjuvant therapy, but they haven't got any lymph node, significant lymph node disease. Maybe they have 1 or 2 lymph nodes, which the radiologist would probably put down as saying probable N1 disease. So in those patients, we don't use TNTs. We're still going for short course followed by delay, because there was evidence, there was a study of short course followed by immediate surgery or short course followed by delay, which showed that delay actually does not compromise outcomes. So we still have a role for short course radiotherapy on its own. And we also have a role for long course on its own. So like somebody who's got T3C disease with the threatened CRM and limited nodal involvement, we would still use long course on its own. So we have actually got divided groups where we use short course alone, long course alone, or the TNT protocols. But if you were to use TNTs, we'd probably prefer Rapido because PRODIS is very toxic. The final comment was that this thing about radiotherapy dates is not actually is a problem in our center as well. We've had a crisis now. We've been really struggling to get radiotherapy dates. So what we decided as a team was like the Rapido has short course followed by chemotherapy, but where we can't get the radiotherapy dates on time, we start with chemotherapy, use capox for 4 to 6 cycles, and then give radiotherapy. So you can get around that. So this thing about you have to have a short course followed by chemotherapy. I think it's, yes, the trial protocol said that, but there's a way around that where you can give chemotherapy first, followed by radiotherapy. Thank you.
Of course. Yes. Can I just ask an open question to the panel and also Dr. Hingorani? Where do you see the lymph node boosting in the context of TNT? Because we started to think about lymph node boost as a SIB for lymph node positive patients. And the standard dose of 45 and 25, we are pushing sometimes up to 54 in 30 for that integrated boost. Do you consider those patients to be able to tolerate TNT, or do you think we are just putting too much pressure and trying to increase a bit more grade 3 there?
So are we talking about nodes, mesorectal nodes? We're talking about pelvic sidewall nodes? What nodes? Because
we are talking about pelvic sidewall nodes, which we
okay.
started to boost, yeah.
Yeah, so we do that actually. I think we sometimes do that if we think, because I think if you have a pelvic sidewall node, then that's outside the mesorectal envelope. So that doesn't come in part of the standard TME surgery. So what we have got, we have a surgeon in Leeds who would actually do a pelvic sidewall lymph node dissection. So in those patients who we think are suitable pelvic lymph node dissection, we would go for a pedo because you can still give them short course. But if you think the patient is not fit for sidewall lymph node dissection because of comorbidities and all, because it's a major surgery, we would then probably go for long course and chemotherapy, because with long course you can boost it, with short course you can't. There's no protocol where you can boost the sidewall with the short course. So if you're trying to boost the sidewall node, we would go with long course then, plus minus chemotherapy.
Absolutely. Do you have any comments from any other panelists, please?
Yeah, we do that also for if you have extra mesorectal nodes, pelvic sidewall nodes, then if you are planning to boost, then yeah, we do a long course, same, maybe a 50-25 to the whole thing and 50-14-25 as a simultaneous integrated boost.
Fantastic. And for this proportion, quite a big proportion of patients with the TNT treatment, whichever route we take, are getting clinically complete response and the endoscopy doesn't show any viable cancer. How do you go forward from that? Do you prefer a period of surveillance, offer them surveillance, or would you still prefer to go straight for surgery because it was a nasty disease at the outset? What I'm trying to ask is, what do you consider as your main goal with some of the patients? Clinical complete response or pathological complete response?
Pathological.
Well, I think, so I think in our center, actually, we're using organ preservation. It's not a standard of care, but somebody wants to avoid a stoma and they don't want surgery. We would say that if you had a complete clinical response at 3 months, you could potentially go on to the organ preservation protocol, but we emphasize that's not the standard of care. We also emphasize that the clinical complete response at 3 months does not mean a true response, because you'll have to go on a period of surveillance, which involves 3 monthly sigmoidoscopies plus minus imaging, and 50% of those patients will relapse within 2 years. And so they need to know that that's not a curative treatment. So having a complete response 3 months does not mean they won't have surgery. So we are developing kind of our patient information leaflets and clear guidelines to manage these patients, because there is data out there, but there's no randomized data to support it. And that's where the patients need to understand that this is still an experimental form of therapy, but Brazilians have been doing this for ages without compromising outcomes. So we are using it for selected patients who are not fit for surgery, or who really want to avoid surgery. So we have a protocol for those patients, but that's not based on randomized data. That's based on the multiple single center series which came out about organ preservation. And in those patients, I think they would still have the neoadjuvant therapy as would be standard. And then if they want to avoid surgery, we'll stage them at 3 months and take it from there.
Thank you very much.
Dr. Desai, thank you. Just like a surgeon, I'm intervening at the moment. So we are at a shortage of time. So it was a very intricate discussion amongst all of us. So it has given us an insight in the neoadjuvant therapy in rectal cancer. So with this, we come to the end of our discussion. Thank you.
Thank you. Thank you, Parth. Thank you for
Thanks,
the
Animesh.
moderation. And thank you, Samina
Thank you, Dr.
Islam,
Animesh.
Dr. Shogat, Dr. Arvind, Dr. Manu Prasad, Dr. Triranjan Basu, Dr. Anish Bandyopadhyay, and Dr. Nikhil Agarwal for participating in the panel. Thank you. Before concluding the session, may I request Dr. Kingshuk Das sir to hand over a memento to our chairpersons as a token of appreciation. Thank you. Moving on to our next session. Our next session is going to be very interesting, and it's going to be about evolving role of immunotherapy in GI cancer. Immunotherapy took a bit of time to get into GI cancer, but now it is showing promising results in metastatic as well as adjuvant setting in esophago-gastric cancer. May I request Dr. Indranil Ghosh sir, medical oncologist at Apollo Kolkata, to come over to chair and introduce our speaker, Dr. Bhavna Shirohi madam.
Good afternoon to all of you. I have the pleasure to welcome Dr. Bhavna Shirohi for this talk, Evolving Role of Immunotherapy in Esophagogastric Cancer. Now, Dr. Bhavna Shirohi certainly needs no introduction. Just for the sake of formality, she is the medical director at Balco Medical Center, Raipur. She has many decades of experience in the NHS as well as in India. And she has published more than 150 papers in various journals. Her research and clinical interests lie in mostly breast and GI cancers. And she is also sits on the ASCO Committee for Health Equity and Outcomes. So without wasting any more time, I request Dr. Bhavna to proceed with her talk.
Thank you so much, Doctor, and thank you, Dr. Animesh, for inviting me to this. I wish I could be there in person. If you could stop, if Kavina could stop sharing the screen, I will just share my screen. Great, thank you. So it's indeed a pleasure to talk on evolving role of immunotherapy, because that is the one development that has happened, which has actually made a difference to our patients in improving not only their quality of life, but also living longer. The center I'm at, less than 1% of my patients can afford immunotherapy, but I'm sure this is the story in over all of India. But I'm hoping that the prices will come down, and hopefully we'll have a biosimilar very soon, so that we are able to treat more patients with this. The Indian data is that the stomach cancers are going down, and I think that's reflective of all infection-related cancers and lifestyle-related cancers like esophageal cancer, mainly related to tobacco, are going up. The treatment strategy for upper GI cancers...
Ma'am, sorry to disturb you. Ma'am, request you to please make your screen full screen.
It is full screen. It's hide presenter view, should I put?
Just a second.
Ma'am, currently you're sharing the tab, ma'am. If you can give me the permission, I'll just... Perfect, ma'am. Now
is it okay now?
Yes, ma'am.
Okay, thank you. So the treatment strategy is, yes, of course, we should, most cancers, we were very lucky in the NHS that we had site-specific oncologists, but we know that in India, we are heavily short of medical oncologists in the country. So we cannot go for site-specific oncology. I would prefer that the treatment has become so complex that we need to have treatment for at least patients with the curative intent in high volume centers and follow some guidelines as well. The ICMR has guidelines, as the Indian Council of Medical Research, and the National Cancer Grid also has guidelines. And so that most of our patients or all of our patients get uniform treatment as they do in the NHS as well. The established routinely that we do for patients is HER2, MSI, and PD-L1. And what is emerging is FGFR2b, Claudin 18.2, and minimal residual disease, which I will not touch actually. I will not discuss HER2 as well. I will just focus on immunotherapy. And because we have a lot of students, one second, I will just stop the video. So because we have a lot of students, I will also talk about mismatch repair deficiency, which is 8 to 10% of our patients with operable cancers are deficient in mismatch repair or MSI instable, and about almost 5% of stage 4 cancers, more likely to be proximal, more likely to be ladies, and higher median age. So recently, the ASCO, the CAP and the AMP guidelines have come in. I think we have to be aware of these because MSI has to be done by immunohistochemistry or by PCR and not by NGS, because this is what we are seeing in the clinic quite a lot nowadays. And TMB should not be used as a surrogate to start immunotherapy. I think if a patient has a high TMB, then one must perform IHC or PCR and confirm that the patient is MSI unstable or has an MMR deficient sample. Like in this sample, there is absence of MLH1 and PMS2. And again, I think these guidelines came in now in October last year, published now, but the approvals happened before. But I'm glad that these guidelines have come out so that, you know, we can follow them for our patients and do MSI in the right way. Again, there is a lot of confusion in clinic, which I face as well. So it's very important to know what the obligate partners are, whether your IHC is truly correct, because based on this, you are going to start patient on a treatment which is very, very expensive. And all of these need to be taken into consideration. And also the patient should be referred for genetic counseling to detect the 10% familial cancers which may come up. And we're again very short of geneticists in India. So telegenetics is the way forward, and this is what I use at my center currently. Why is MSI testing so important? For early or locally advanced or operable gastroesophageal cancers, it is a prognostic and operable. And I think nowadays we are questioning whether some of these patients truly need to have chemotherapy at all, because they are actually chemo-resistant. And this has been shown in MAGIC and the classic study, and also in the meta-analysis, that there is no benefit of chemotherapy in patients who are deficient in MMR. MMR is also predictive in advanced patients with advanced cancers. So the future is MSI-driven therapy, and I think in operable cancers, there are trials going on with immunotherapy with the Neo-adjuvant. The study with the Neo-PPGA trial showed a complete pathological response of almost 60% in patients who had Neo-adjuvant nivolumab, ipilimumab, and again, the first-line studies have shown greater response rate in patients who have MSI high tumors. Whether we can avoid giving them chemotherapy and just recommend surgery, I don't think we are there yet. But if I have a patient who's had surgery and has had an MSI high tumor, the performance status is borderline, or an elderly patient, then I have less hesitation in recommending that patient for upfront surgery or maybe avoiding chemotherapy post-operatively. But again, that is in those patients where the decision is borderline. PD-L1 testing is the other test which actually drives immunotherapy in our clinics. And again, there is a lot of there are a lot of issues relating to PD-L1 testing in all cancers, especially in upper GI cancers, the platform to be used, the antibody to be used, the subjectivity with the reporting from the pathologist and the result interpretation, whether you use combined positive score or tumor positive scores. And again, each of these agents has a companion diagnostic. So you have to use the right companion diagnostic. I will not going to spend too much time on it because this is a half-an-hour lecture. And I heard to a couple of my colleagues, Raghav Sundar and Elizabeth Smith, talk about it. And I think if you want to, you must listen to those lectures because, and the other thing is that PD-L1 testing is dynamic and changes with chemo and radiotherapy. So when you're doing your adjuvant decision-making, how do you go about it, especially in patients with residual tumors? So coming on to the studies, again, I'm going to discuss the pivotal practice-changing studies and not all the studies which have been done with immunotherapy because of paucity of time. This is a randomized clinical trial, double-blind, with patients who had residual disease after pathologic disease after neoadjuvant chemo-radiotherapy. And with good PS, almost 800 patients. They were randomized to nivolumab and placebo and given up to 1 year or until progression or toxicity with a primary endpoint of disease-free survival. These patients were followed up for 2 years. And I think this trial is very important because we know that in these patients, the risk of recurrence is almost 70 to 80%. So I think we need to do something different to see whether we can decrease this risk. And as you can see that the disease-free, the study met its primary endpoint and is practice changing, that patients who had nivolumab had a significantly better disease-free survival of about 22 months, almost double, 11 versus 22 months. And if you look at the histology, and we know with immunotherapy, the squamous cells, or with radiotherapy, the squamous cells tend to do slightly better. And this is reflected here as well, that the patients 19 versus 11 versus 30 months versus 11 months in squamous cells. So the benefit was definitely higher. The one thing I would like to point out in this study is that, which was quite interesting for me, was that patients who received nivolumab, the magnitude of benefit with respect to the DFS was greater in those who started it about 10 weeks after surgery than in those who had it before. I think this is reflective of the intensive treatment of chemoradiation and surgery. So I think there is a prolonged recovery needed for these patients before they can start another intensive treatment with immunotherapy. I just want to talk about this one study. Again, I know it's a negative study with adjuvant durvalumab and squamous cell esophagus, 86 patients, small number. This study did not meet its primary endpoint and showed that there is actually no benefit of adding adjuvant immunotherapy with durvalumab. But again, it's a small number of patients. The control arm, that is the placebo arm, did amazingly better. And but this study showed that that the post chemoradiation PD-L1 status can help predict the survival of patients who received adjuvant PD-1 or PD-L1 inhibitors. And this study had also included patients with pathological complete response. So I think we must keep this in mind, especially with whether the different drugs are different. That could also be, but again, it's a very small study. Coming on to the first line patients with advanced esophago-gastric cancer. I will take up adenocarcinoma, the checkpoint 649 study first, which randomized patients to nivolumab plus fluoropyrimidine platinum versus standard chemo Capox or Folfox versus Nivo-Ipi times 4 followed by nivolumab alone given every 2 weeks. Almost 2,000 patients recruited in this study, the co-primary endpoint of overall and progression-free survival, especially in patients with PD-L1 with a CPS of 5. And as you can see, the study showed that this was a practice-changing study and led to approval of nivolumab. This showed that patients did live significantly longer, 14 months versus 11 months. The benefit was almost 2 months for a patient who received nivolumab. The patients had a two-year follow-up with a hazard ratio of 0.70 for PD-L1 CPS more than 5, and there was no overall survival benefit for patients whose PD-L1 was less than 5, though the overall response rate was independent of the PD-L1 status. So coming on to the third arm, which was published last year, the Nivo-EP arm versus chemotherapy. They looked at the secondary endpoint of overall survival, and actually this did not meet its pre-specified boundary for significance. The response rates were lower than chemotherapy, and I think this could be due to, as per the authors, early mortality with the Nivo-EP. And most of us who've used ipilimumab know that how toxic the drug can be related to its side effects. Versus chemotherapy, and also there's a crossover of the Kaplan-Meier curves. If you look at the immunotherapy in first line, these are the 3 pivotal trials: Keynote 062, Checkmate 649, and Orient 16, done in China. In the last 2 studies, almost 60% patients had a CPS score of more than 5. And all of these studies are positive in favor of use of immunotherapy in first line setting, and the benefit is more. So I'd like to bring your attention to the grade 3 to 5 AEs, which are not insignificant, which are almost 60%. And these do increase. The cost of drug is high, but the cost to the patient, the financial toxicity to the patient as a result of the AEs is also quite significant, which we must not forget. Coming on to the second study, which is Checkmate. This is in squamous cell cancers. Patients were randomized to nivolumab plus chemo. So the 5-FU plus cisplatin versus Nivo-EP versus chemotherapy, very similar design. Again, this did show that there was patients who had a PD-L1 expression of more than 1%. There was a significant benefit in overall survival, almost 15 months versus 9 months, and also in overall population, 10 months versus 13 months. And the progression-free survival was also significantly better in squamous cell. If you look at the Orient 15, that also showed that patients with first-line advanced metastatic squamous cell esophageal cancer did significantly better. And this study actually shows the clinical utility of a marker that doing PD-L1, whether it's CPS or TPS, both of these showed that there was a significant benefit. So this actually shows that the marker is robust, though there are challenges with it, as we know that. If you look at the regulatory approvals, which are FDA or EMEA approved, again, both for squamous cell and I will not discuss the second line data or third line because for adjuvant, I think nivolumab, again, irrespective of biomarker, is approved for those who have residual disease. Pembrolizumab for first line, again, no biomarker by FDA, but EMEA would like a PD-L1 CPS of more than 10. I think the whole point of this slide is the approval is different. So I think in each of your countries, it is one has to look at what the approval is. In India, I think we tend to follow EMEA, and which is more towards resource limited patients. And for me, I would actually do the PD-L1 CPS score based on the companion diagnostic before considering patient for immunotherapy, because we know that the magnitude of benefit will be larger in these patients. And again, TMB is there in second line gastric, as you can see, more than 10 mutations, but the current guidelines that have come up actually say that TMB high alone should not be taken as it should. The patient should have an MSI high cancer as well. So I think briefly, I would say that MDT care absolutely essential. NGS I have not discussed, but this is something again which we do, but it should not guide the treatment decision making for MSI or with just TMB alone. MSI testing, very important that it is done robustly, and we should consider genetic assessment. PDL1, I would suggest using a validated assay and platform. Adjuvant decision making, if PDL1 is to be used, whether it should be, the PDL1 should be tested before at diagnosis, and sometimes we do it on the archival sample, or should it be done in the sample post chemoradiation in those patients who do have residual disease, which is, I think, what we should do, because it is dynamic and it changes. It does improve survival both for adenocarcinoma and squamous cell carcinoma, though the greater benefit is seen in biomarker-enriched population. I have not spoken about EBV, but that is also coming up as a marker that these patients tend to have a better prognosis. We know that in head and neck cancer, the treatment has been de-escalated in patients who are EBV positive, sorry, HPV positive, not EBV. So, but in gastric cancer, we know that these EBV positive patients have a better prognosis and are more likely to have an MSI high or a PDL1 positive cancer. Thank you.
Thank you, Dr. Bhavna, for another excellent lecture. If there are any questions in the chat box.
So Dr. Indranil, I have a question. This is Ankur.
Hi, Ankur. How are you?
Yeah. I'm good. So, madam, I have a question. So many of our patients come to us as a second line or a third line therapy. And initially they have got platinums, 5-FU, taxanes, or whatever is the standard first line therapy. When the patient comes to us second line and third line, so do you use this immunotherapy with combinations with chemotherapy? Suppose PDL1 done and PDL1 comes out to be, CPS comes out to be 20%. So are you keen on adding immunotherapy with chemotherapy in second line, third line in stomach or esophagus cancer? Is there a data behind it?
So, I mean, there is some, but not very robust. So what I tend to do, let's say gastric cancer, I tend to use second line, I tend to use paclitaxel ramucirumab routinely. And then I reserve immunotherapy for third line, because, you know, the data for ramucirumab taxane is quite robust in second line in gastric cancers. But let's say if you have an esophageal cancer or a squamous cell cancer, then I have a low threshold of using immunotherapy. Then, you know, I tend to go more in favor of immunotherapy rather than ramucirumab and taxane.
So just one last 10 seconds. If a patient comes to you post FOLFOX as a second line therapy and CPS is 20%, you will use Rainbow Regard or you will use taxane plus immunotherapy?
So I think I would use taxane plus again, you know, most of these patients, Ankur, they have third line, fourth line. So there is no right or wrong answer. You can go for second line immunotherapy as well, along with if they, depending on the disease-free interval, I would use FOLFOX again, or use irinotecan single agent, or along with paclitaxel or FOLFIRI. So these would be your chemo backbones. But I mean, you would not be wrong in adding immunotherapy second line if the CPS score is 20. I mean, the patient is very likely to respond to immunotherapy.
Thank you.
Thank you.
Yeah. So there is one question by Dr. Roshni. What about combining HER2 new targets with IO? I think you briefly.
So again, we have the keynote study which shows that, you know, my first line for patients with, I just have a couple of patients who are on FOLFOX, trastuzumab, and pembrolizumab. The CPS in this patient is more than 5. But, you know, it is irrespective of CPS also, you could combine it.
Yeah, but as you showed, it is not yet approved by the EMA, only by the US FDA.
Absolutely.
Yeah. So, thank you, Dr. Bhavna, again. Hope to see you again in a short time. Till then.
Thank you. Thank you so much. Thank you.
Thank you, madam. Thank you for.
Thank you, Dr. Animesh. Thank you all.
So before concluding the session, may I request Dr. Mano Shah, sir, to hand over a memento to Indranil Ghosh, sir, as a token of appreciation. So we'll be moving on to our penultimate session. It's a very interesting debate. Both of our chairperson couldn't join due to some unavoidable circumstances. So I'll take the privilege to introduce our debater. The topic is SABR is superior to other local ablative technique in medically inoperable hepatocellular cancer. And we'll start with Dr. Ganesh Radhakrishna, who will be speaking for the motion. So Dr. Radhakrishna is a senior consultant clinical oncologist working in the Christie NHS Foundation Trust, Manchester. His main area of interest in GI cancer, including hepatopancreaticobiliary cancer and precision radiotherapy. He is a member of RCR Professional Standard Subcommittee and RCR Equivalence Committee, tutor of postgraduate clinical education course at University of Leeds. Over to you, Dr. Radhakrishna.
Good afternoon, everyone, and thank you, Animesh, very much for inviting me to speak today, and all the organizers. I'm going to try and share my screen, if that's okay, to see if it works.
So please go ahead.
Thank you. Thank you. Are you seeing my slide deck?
Right, sir.
Yeah, you got it. Brilliant.
Yes,
thank you. So once again, thank you very much for the invite, Animesh and the organizers. Good afternoon. I hope everyone is okay. It's a long morning, but it's been a fantastic session. So congratulations to all of you. I've really learned loads. As the Congress actually highlights, it's about controversies. And so the first controversy is I've changed the title, as you will see. So I'm going to try and persuade you that actually binary discussions about superiority may not be the best argument for modern precision oncology. So I've changed it to SABR may be superior in medically operable HCCs in certain circumstances. So let's declare the issue that we're dealing with. There is no level 1 evidence to demonstrate superiority, quite frankly, of any ablative technique or one over the other. However, absence of evidence is not evidence of absence. And I think that's an important starting point, because we are very much at the inception and very much, I think, at the infancy of using non-surgical ablative techniques. I hope there are no surgeons out there in the audience, because I think, ultimately we want to render surgery as very much the final option and reserve it as the option of least preference. So very quickly, I'm going to give an overview about SABR and the evidence base in HCC, introduce the concept of combination therapies, because I think this is where we'll be going in the future. And we've already heard a fantastic array of speakers talking about the combination of systemic therapy, particularly immunotherapy. And I'm going to try and introduce a little bit of that here and highlight the research and innovations in progress within the radiation sphere. So this is the UK Consortium guidelines. I think it's a very good start in terms of describing what I'll be talking about today. So stereotactic ablative body radiotherapy is precise irradiation, and that's quite important because we'll be talking about high-end image guidance and also using a high dose per fraction, and that does matter. Dose matters. It is our scalpel in radiotherapy. So most of you will be familiar with this diagram looking at the use of the Barcelona Clinic liver classification and the treatment strategies available. And as you can see here, ablation falls within the area of very early stage, particularly for patients who may not be suitable for resection, but also patients who may not be suitable for transplant. And so we kind of are in this early stage, early Charles Pugh criteria for HCCs. And I think in time, we may start to encroach, and I think about this, about all ablative techniques rather than specifically SABR, encroach into the intermediate stage as well. But that is an area of further research. So I think we need to start looking at this in a more precise and personalized way. And I think some of my colleagues who were in the discussion for the rectal cancer seminar earlier suggested that we need to look at individualization. And in the UK, we're very much into the term personalization because one size does not fit all. You know, every patient is different. They have a different molecular profile. We've heard all of that already. But also, I think that increasingly, we're beginning to understand, particularly from our colleagues in the Far East, that patients who have viral-driven background cirrhosis may respond better to radiation therapies. And I also think we should avoid comparing apple with pears. And one of the things that Jonathan highlighted in the pancreatic session is, the comparison with ASPAC-5, where we were comparing systemic therapy with a local treatment, chemoradiation. And I don't think it's any surprise that actually chemoradiation was still better than surgery alone, but fundamentally was inferior when you're treating a systemic disease like pancreatic cancer. And so to start, let's start with data. And this is a very interesting paper that was published in JCO, comparing RFA to SABR. And it fundamentally suggested that RFA was superior. But let's be clear, we are comparing patients who initially were treated about 20 years ago. And you can see here already in this column here that many actually didn't even have a SABR at that point. And I think this is where we need to understand that SABR, like RFA, like TACE, like surgery, is a craft specialty. And so there is a learning curve. And this was very much at its infancy when it was starting. I think the other thing to sort of look at is the other factors that we know affect outcome. We know that tumors that are smaller in size will respond better to RFA than SABR. That may change as we are able to optimize the dose. But at the moment, if you have a peripheral lesion which is quite small, you would probably go for a thermal ablative technique. Certainly we would in our center. Most patients had suboptimal doses of SABR, and there was really no multivariate analysis looking at particular areas like the Charles-Pugh score and PVTT. And that's important because particularly at the early phases of introducing SABR and all the early studies, we took the ugly HCCs because we were starting to introduce this treatment in patients who had been heavily pretreated, and that's certainly the experience in the UK as well. But this is 10 to 20-year-old data, and it's comparing apples with pears. That is not to suggest one's treatment is superior to the other. It's just that we don't know what may work for a specific patient. And this is a very nice little review article which sort of highlights where SABR or radiation treatment, which I'll be talking about in more detail, may fit. These may be patients who have a peripheral tumor which may be too large to get a good burn, patients with more comorbid and poorer outcomes, those with PVTT, particularly patients who in this group who may respond to other forms of radiation therapy, still looking at SABR. I'll come to that in a minute, and also if there is difficult access. I also want to introduce the concept that, patients aren't, it's not one size fits all, but it's also not one treatment for everyone. Actually, the combination of these treatments may actually be much better than just looking at unilateral decisions or single modality treatments. And this is quite interesting because this is two cohorts. So these are European cohorts of patients who were treated with TACE and SABR. And you can see the patients who had combination therapy in the dark line did better across all the outcomes. And this is in the Far East population. Once again, you can see patients who had and TACE or TAE did better than just single modality TACE. And this may be because in certain instances, patients who are receiving TACE or TAE may not necessarily have got an adequate or may have got a suboptimal treatment with it. This is, so HCC Sabre is now commissioned by NHS England. We use it routinely for a very strict criteria that is defined by NHS England. And this was on the basis of our commissioning through evaluation program, but also on the basis of this meta-analysis, which looked at 109, over close to 2,000 patients, which demonstrated a high local regional control rate and overall survival. And for patients with much larger tumors that would usually be associated with thermal ablation. And so we still have a reasonable control rate. On the basis of that, we were approved, and that's what we're doing now in the UK. But I also want to highlight data which is more concurrent with the current era. It's more relevant. So this is data that in the main is looking at the 2020s, but we have one outlier here, a couple of outliers here further down the line. The main thing to highlight with that is this is where I'd like to highlight the learning curve. So Sabre, we know that the liver is very radiosensitive, and if you don't get it right, you will cause damage. And you can see that the rates of RILD and grade 3 toxicity were particularly high. But as time goes on, you can see that that is starting to diminish. And that's good, because obviously we're improving our techniques, we're understanding our craft, but also I also want to highlight the inclusion criteria here, that some of these patients had more advanced BCLC grades of their disease as well. But what we can see, but particularly with this group, is we are looking at very high local control rates and survival rates with Sabre or SBRT. And what about the current treatment options and research in external beam radiation? So one of our colleagues, Jonathan Wadsley, highlighted the option of MR guidance. This is an example of the improved imaging that one can get with MR-guided adaptive radiotherapy. MR-guided adaptive radiotherapy involves real-time planning. So we plan on the fly whilst the patient's on the couch, and that might optimize the radiation dose and ensure we're getting a good biologically equivalent dose for treatment. This is not probably the best example of a cone beam CT. I think they've particularly selected a poor cone beam CT. We don't see so much graininess and loss of and so much artifact on our conventional current modern linear accelerators. But I think it just does highlight the difference that we can get with image guidance. And that difference is important because if we're more confident we're hitting the target, we can start to reduce volumes and escalate the dose. And we're using this for pancreatic cancer currently at the Christie. And as image guidance improves, the next thing is that we are also able to optimize treatment based on functional imaging and embedding functional imaging into our planning system. And that will be also useful because potentially that may reduce our risk of radiation-induced liver damage or other comorbidities. And so this is a study that we are now embarking upon, trying to look at using functional imaging. And at the moment, we're very much at the planning stage of it, but we hope to integrate this into our planning for HCC patients moving forward. And we use multimodality imaging as standard. So we use MR and CT for our radiotherapy planning, and hopefully be onboarding these patients onto our MR-Linac very soon. And the other new kid on the block is proton beam therapy. Proton beam enables us to, as you can see here, the proton beam enables us to spare a substantial amount of liver and other tissue. And so we're looking to see if this might improve things. We know from the group, particularly in Korea, who have a high incidence of viral-driven HCCs, but with high rates of PVTT, that particle beam, particularly protons, may do better even than Sabre. So a couple of final slides. We are going to be involved in the NRG US study, which is comparing protons versus photons. So this will be an interesting study, once again, looking at Saber fractionation and seeing if there is a role for PBT and identifying and stratifying patients who are most likely to get a better outcome from protons and potentially treat bigger tumors. And as highlighted by a prior speaker, the role of immunotherapy. And this is a really nice image highlighting how SBRT or Saber specifically has quite a powerful antigen presenting element, which we can then upregulate by adding in checkpoint inhibitors and then achieving that, which is pretty much the unicorn of radiation therapy, the abscopal effect, where we may be able to advance metastatic or systemic control by immunosensitization with SBRT. And we can see that there's some promise with some recent studies coming out, particularly from North America, looking at that. And we will be embarking upon the ratio study, which will be looking at SBRT plus and other radiation therapies, including proton beam, in the metastatic setting with checkpoint inhibitors to see if we can enhance the efficacy of immunotherapy in these patients. So in conclusion, I think there's lack of evidence of superiority of any surgical, non-surgical single modality liver-directed therapy, but I'm not sure that that necessarily is a relevant question for patients. Treatments have evolved, and I think our expertise in Saber has evolved as well. And combination therapies may be more effective, but either in sequence or in concert. And research really should be focused on personalization, expanding those non-surgical indications. I've got my email at the bottom, and I'm happy to take any questions offline in the future. And once again, thank you for the opportunity to present today.
Thanks a lot, Dr. Radhakrishna. So our next debater, Dr. Dayananda Lingegoda. Dr. Dayananda sir is an intervention radiologist with vast experience in tear, TACE, and other ablative technique. And he is currently working in Tata Medical Center, Kolkata. So he will be speaking against the motion. Over to you, Dayananda sir. Sir, you need to unmute yourself. Dayananda sir, you need to unmute yourself.
Can you see my slides?
Yes, sir.
Okay. Good evening, everyone. At the outset, I thank Dr. Animesh Saha and Dr. Tanmoy Mukhopadhyay for giving me this opportunity. Thank you for Dr. Ganesh Radhakrishnan for such a honest presentations, which is very rare to see nowadays. And a couple of years back, actually, we had similar meeting where the topic for debate was where the SBRT was whether equivalent to the local ablative therapies. Now, with 2 years down the line, now there is a lot of aggression. Now, the topic we are discussing is whether the SBRT is superior to the ablative therapy. If someone is saying it's the ablative therapy is superior, also means that it is superior to the surgery, because for a long couple of decades, actually we consider ablative therapy is equivalent to surgery. If somebody is claiming it is superior to the ablative therapy, it also means it's superior to surgery. So I am a very conventional guy. Let us start with a basic principle. The ALARA principle, all of you know about it. If ALARA principle says that if there is two modalities of investigation, if one modality is a radiation and another modality is non-radiation, it is wiser to choose the non-radiation modality as a treatment. So if you consider it is equivalent, actually there is a logic to choose an ablative therapy over the radiation therapy. So whenever there is a problem, actually we look into the guidelines, and this is the BCLC guideline is like a most popular and widely accepted guidelines. So this is a recent update. We cannot scrub it as an old one. So this is a recent update, and here you can see there are few changes have come where now the ablation is actually preferred modality for the very early stage disease. And also previously the tear, which was actually we are working on more on the BCLC stage, now it is upgraded and given, and we can see, so we can use these transarterial radioambulations in the early stage and intermediate stage SCC. In these treatment options, I don't see any recommendations on SBRT, and NCCN guidelines also like this do include the SBRT in the guidelines, and it says that there is a blanket evidence which is given. It's a 2A. I was a little bit surprised to see a 2A in this category because there are modalities which this is persisting for many decades, and I was a little bit skeptical how come the recent modality which is included as 2A. But when I look into the details, actually it says that actually the 2A for the panel recommends EBRT or SBRT to consider as alternative to ablations or embolization technique when these therapies are failed or contraindicated. That means they are actually already they are considered not as a primary treatment. Only in those cases which are where these ablations is not possible, then only you need to consider for a EBRT. This is for a 2A evidence. And let us see this is Astro guidelines. I just looked into it just to see what is happening in Astro guidelines. There are three strong recommendations in these. Let us see what is these strong recommendations. This one strong recommendation is patients with a liver confined to SCC who are not a candidate for curative options and their own catheter-based therapies being not considered, then EBRT are recommended as a potential first line as a single. So that means when these options are not considered, that means it is not equivalent the modality for treatment. Also, another recommendation is the EBRT can be considered when there is a recurrence, incomplete response after thermal and catheter-based therapies. Again, that means that EBRT considered only if these modalities are fails. That means the thermal ablations are given the preference over the EBRT. And another strong recommendation is this patient with locally recurrent SCC after surgery and after thermal ablations. So again, this already they accepted that the thermal ablation, surgery, and catheter-based therapies are the primary modality for treatment. So let us look into the ESMO guidelines where they have divided into standard care and also alternative treatment. In the standard care, we can see the resection, thermal ablations, and transarterial ablation TACE as in the standard care. With even the TACE is the level 1 evidence with a grade level A recommendations, and we can see the SBRT in the alternative treatment, not in the primary standard of care. So these again the ESMO guidelines. This is the standard treatments which is the resection, ablations, and also TACE, which is a level of evidence. And SBRT is mentioned, but they have given a suffix with it is classified under non-standard alternative treatment should be considered one. These modalities, primary modalities, is not possible in subset of cases, not as a primary indication. Again, I looked into China guidelines, which says that actually only this stage 3 onwards only I could see radiotherapy, and again it's similar to the rest of the guidelines. So let us look into the other American guidelines, Europe guidelines. We've already seen Japan and Korean and guidelines. Again, it's almost they are similar, and they've given the standard of care in the initial category is actually resection, ablation, transplant, and only in Korean guidelines the radiation is given a place where there is as an alternative treatment or when there is a portal vein involvement. Otherwise, standard of care is still a resection, ablation, and transarterial radioembolization. This is a gist of all the world recommendation. If you combine, again, this is as a standard treatment and is alternate treatment, and the first category treatment, I don't find any BRT in the these recommendations. And we are forgetting what is the impact of SBRT radiation on the liver. Actually, this is a paper which says that SBRT has a moderately negative impact on the liver functions, and and this is very, very important when the patients are subjected to the or downstaging, or patient is already cirrhotic. The future, what is the quality of future liver remnant we are going to give? Especially in the ablation and transarterial ablations, generally we don't touch the normal liver. We only try to treat the disease. But it is not the case with the radiations, where there is a normal liver, future liver remnant. What is remaining also, there is not a quality of the quality of future liver remnant is questionable. This is like a liver toxicity which is reported. There are some measurable radiation toxicities, like a total rise in total bilirubin and alkaline phosphatase and cholangitis, and also non-measurable toxicities are also mentioned. And also there is a hepatitis B virus reactivation, which is also mentioned because of immunocompromise. These kind of toxicities are generally not seen with the ablations. These are the ESLA clinical practice guidelines, very good slides. Actually, it's some of all the evidences. Here this row we can see the evidence according to level of evidence: low, moderate, and high. And it is and this horizontal level we see the positive recommendations and negative recommendations. In the positive recommendation and with high recommendations, where we see the chemoembolization, radiofrequency ablation, and also along the resection. And the external beam radiation, actually in the fence, it is in between the negative and the positive, and but with a low recommendation. What is this recommendation means? When there is a strong recommendation, which means that the further research is unlikely to change our confidence in these estimated benefit and risk. So there's a strong recommendation for resection, ablations, and TACE. These recommendations comes with not with a small studies. These comes with if you see the studies with analysis, there are 10,000, 20,000 patients. So this is a level of evidence we gathered over the decades. This is an example. I want to conclude with this example. This is a lesion. There's a central lesion, which is a large lesion, one dimension. It is measuring 10 centimeter, another 15 centimeter. After one TACE, we are seeing a complete response. There is no confusion in the treatment post-treatment scan, like whether it is a residual disease or there is a complete response. We have had an opportunity to see a couple of post-radiation liver changes, very, very difficult to interpret in those cases, because there are a lot of confusion and very difficult to report also. And I'm not going into individual studies because the integrity of a small studies are very, very questionable. And if you're good at statistics, these are very, very, very famous book where says if you know the statistics, you can screw it up and you can get a desired results. That's what we are very bad at statistics, but still this is a very classic example. If you want to make a Vinod Kambli as a very great player, maybe you can consider only the Ranaji of his scores, and we can make him as a very great player and discard the international scores, telling that they are not matchable. With this, I thank you very much for giving me the opportunity, and leave the over to Dr. Animesh Saha.
Excellent presentation. May I request Dr. Radha Krishna for some rebuttal comments against the talk of Dr. Dayananda? Because 1 minute for rebuttal comments.
Thank you. Thanks very much. I think, as I highlighted at the early stage, we are very much at the early stage of developing our experience and expertise in SABR. I think that is what's reflected in guidelines. So guidelines, like textbooks, often are outdated by the time they are published, but one can't deny the merit in the argument that has been presented. And I think actually going from controversy to consensus, I think we'd agree that there is a role for SBRT, but particularly in a particular cohort of patients as outlined in my presentation. I think the only thing I'd like to suggest is that in this situation, we need more data, and I hope my colleague will agree with me that we need more data and we need more research in this area. And actually, a combined approach may be useful. So I didn't bring any of my good slides to show a response, but one of the things that we sometimes do is where we have patients who have two multifocal HCCs, where we may need to use a thermal ablative technique and SABRE technique for a central tumor. And finally, in terms of the issue of RILD and the slide that you presented in terms of the non-classical, classical RILD, and now what we understand, which is central tumors, those are sort of things that we're beginning to understand now and beginning to be able to manage. And that's where I think potentially the role of PBT or these liver-sparing treatments with radiation may have a more pronounced role. So thank you. I'm hoping we're on consensus now.
Yeah, Dayanand sir, I've got 1 more minute for any rebuttal comments.
There is a lot of scope. I agree. There is SBRT is a lot of scope to play when we work together, and especially when we are looking towards SBRT, especially when there is a portal vein thrombosis that can combine with TARE, combine with stasis, in benefit of patients. Maybe it is a combination is the way to go. Synergy is the way to go.
Yeah, very important point. We've got a question in the chat box.
So Animesh, I have a question. This is Ankur Behel, and this question is to Dr. Ganeshan and Dr. Dayananda, if may I ask?
Yeah, go ahead, sir.
Yeah, so Dr. Ganesh and Dr. Dayanand, at times we have multiple lesions, bilobar lesions, and there's a big portal vein sitting on main portal vein, big thrombus, tumor-related thrombus, and the tumor and the case is being discussed in multidisciplinary tumor board. So we know that we need to dissolve this thrombus through SBRT, and for that bilobar lesions, we require a tear for the best outcomes. So at times, and the patient is still in child PUG A. So my question is, how do we actually start? It should be an SBRT to the main portal vein, or we should start with a tear. At times, the patient loses, the caretaker loses the goal, and we land up progression of the disease. So which modality to start with, SBRT first, or a tear first, or a tear first followed by an SBRT to the main portal vein?
The portal vein thrombus is the one which is going to decide the survival. So I would like to start with the SBRT first and see the response. If the SBRT fails to dissolve the portal vein thrombus, maybe should consider the more of a systemic therapy rather than going for a tear, because the portal vein thrombus is the one. Either we have to address this with the SBRT, or we should address with, if we are able to cannulate if it is very vascular, sometimes we are able to cannulate that feeders and we can embolize. That is also another option. But we should address the portal vein thrombus first. That is a gist.
Okay, and in your experience, what is the success rate that SBRT dissolves that portal vein thrombus and improves the child PUG or improves the liver functions?
So I've not seen many cases of SBRT in our hospital. Mostly we only a couple of cases have, so I'm not difficult to say with my experience alone. But I've seen in other centers they are getting very good results when they're for a portal vein thrombus per se.
Dr. Ganesh, any experience with SBRT to portal vein thrombus?
Yeah, so but not in this context. So I think, in the UK, a patient with multifocal disease with that extent of disease would go down the systemic therapy route. So they'll probably be getting atezo-bev if they're child's PUG. And then we may sequence treatment depending on their response after that. I think the interesting data here will be, particularly the role of particle therapy and PPT, because, you're sparing a lot more liver. And then if you're then going in to give another liver-directed therapy, as highlighted by my colleague earlier, it may spare a lot more of the risk of background liver damage. So I think the short answer is I don't know, but often in the UK anyway, we'd probably be more inclined to treat that with systemic therapy.
So Dr. Ganesh, one question that if given a chance, would you like to radiate the portal vein and the liver lesion together, or you will give a gap between them? Because we have seen that post SBRT, there's a couple of lots of hepatitis which happens and it deteriorates the liver function, and we are not able to give our systemic therapy, atezo-bev or even lenvatinib, sorafenib with
Correct.
that extent.
Yeah. So I think that the tricky issue there is, you need to speak to radiation oncologists, the clinical oncologists, and they need to look at the scans with you to sort of work out what is and what isn't possible, because it's about getting the dose in and knowing how much you're going to spare. So I think, it will be a case-by-case basis. But in my personal view, I think as much as possible for the ones that we've treated, we treat the tumor thrombus and the primary at the same goal. Yeah.
Okay.
I think Dr. Hingorani want to make a comment. Can we allow Dr. Hingorani to make a comment? Dr. Mohan Hingorani has raised hand.
Yeah, I think thanks. Yeah, I won't take long, but that was an excellent presentation, both I think Animesh and Dr. Dayananda. I think I work in a center in the UK where I don't have SBRT for liver lesions, but particularly for HCC. So we do SBRT for oligometastases, but not liver actually for node and bone. So we have a problem. So when we have HCC in our clinic, in our NDT, which is not suitable for surgery, we probably go for either RFA or TACE options. So my question to Ganesh was that, can you give me a specific example where you would think that the patient does need a referral for SBRT? Because I guess the evidence is that they're all probably equivalent as of now, but is there any specific example where you think I should probably be trying to push for SBRT?
So I think, the ones that we discuss through our MDT are the bigger tumors, the central tumors are the ones that are segment 8, segment 7, where, you've got the lung interface there, where we'll access that and we won't need to compromise anything in terms of getting the dose in. So those are the ones that preferentially at the moment, my colleagues in hepatology and interventional radiology kind of let me have, if that makes sense. But the other option, Mohan, is just to go in for one of the standard ablative techniques, so TRE or potentially RFA, MWA, and then come back and treat that with SABRE afterwards. So,
yeah, and you're the leading expert on protons there at Christie anyway. So have you been using protons? Not as yet for treatment?
We're not allowed at the moment. NHS England is not signed us off. So we will launch with NRG. So when NRG comes online, hopefully in the next few months, the UK will have access to proton beam therapy.
Okay, that's great. Thank you.
I think we are running short of time. We have to conclude our session here.
Thank you.
So thank you, Dr. Ganesh Radhakrishna. Thank you, Dr. Dayanand sir. We'll be moving on to our last session. We have a panel discussion on HCC. I'd like to invite Dr. Jibok Bhattacharya, radiation oncologist, Apollo Kolkata, Dr. Kingshuk Das sir, gastroenterologist, to chair the session. I'll also ask Dr. Manos Saha to join the chair as a chairperson as well as a panelist. Manos Saha sir is an intervention radiologist working at Apollo Kolkata. May I request the chairperson to introduce our moderator as well as the panelist?
Yeah, before we go there, Animesh, it's a fantastic session. Being a gastroenterologist medical, I've learned a lot from the post-lunch session. And in fact, what Dr. Ankur was saying, I think in this session, half of the things are more or less covered by both the debaters, Dr. Ganesh and Dr. Dayanand. There's a huge interaction, so we learned a lot from them. As far as if I am supposed to introduce Dr. Ankur, everyone in the audience and viewers, everyone knows him, Dr. Ankur Bayal, who started his journey from MAMC, as I remember, and he went to EMS, and from there now he is the Director of Medical Oncology, Fortis Memorial Research Institute, Gurgaon. And I think, Jibak, you introduce the panelist.
Good evening, everyone. So I will be introducing the panelist, Dr. Venkata Krishna Reddy, who is a radiation oncologist from Mahatma Gandhi Cancer Hospital, Visakhapatnam. Dr. Tanu Chawla, Tata Medical Center, Kolkata. Dr. Amit Kumar, Jayprabha Medanta Super Specialty Hospital, Patna. Dr. Manu Saha, he is with us. He's an intervention radiologist with from Apollo Hospital. Dr. Ritika Harjani Hinduja from PD Hinduja National Hospital. She is a radiation oncologist. And Dr. Shruti Banerjee, GI and HP hepatobiliary surgeon from Tata Medical Center, Kolkata. And Dr. Istiaq Rahim, radiation oncologist from Square Hospital, Bangladesh. So to Dr. Ankur Bell for the
Yeah, thank you, chairpersons, and thank you, organizers, for giving me this opportunity. And can I present my slides? Yes. Yeah. So we have heard the previous speakers, the local therapy, the intervention radiologist, the radiation oncologist, but I believe that hepatocellular cancer has changed so much that now, as a medical oncologist, as an oncologist, I have so many options in child POG A and so many options in early child POG B that now I have to choose between therapies. Now I have to choose which therapy gives the best survival. And out of very costly immuno and bevacizumab combination, the IMBRE 150, the atezobev, we have very cheap drug, which is lenvatinib, and we've been using sorafenib long. And we have seen the transition that in last 5-6 years, the sorafenib is actually out of the practice. So lenvatinib is the main drug. And now lenvatinib in combination with IO or IO in combination with bevacizumab has suddenly changed the scenario. And now we see what we call is the overall survival. Now we call it disease control rate. We see the response rates in hepatocellular, which 12 years or 10 years or even 8 years back was declared as a death sentence in a patient with chronic liver disease. So next slide. So hepatocellular carcinoma, we know still in India, hepatitis B, hepatitis C, and lately coming up is the alcoholic liver disease, the NASH related disease, which is coming up. And now even we have a literature published in Nature, which differentiates these two diseases, hepatitis B and hepatitis C related chronic liver disease giving rise to HCC, and alcoholic liver disease or a NASH related CLD giving rise to HCC has a different approach. And this is what I'm going to emphasize in next half an hour, that in which patient to use which drug and how to choose that drug if all three sorafenib, lenvatinib, and atezobev are applicable. Next slide. So I would straight away go to the senior most Dr. Reddy, the radiation oncologist, and Dr. Kanu Charan Patro, radiation oncologist. So do you see the incidence of HCC going up, and do you see that the mortality in HCC going down? This graph clearly states that the blue graph is the incidence is rising, and suddenly the mortality between the incidence diagnosed case and the death is there's a gap. So how do you explain this gap, Dr. Reddy and Dr. Patro?
So sorry, but Dr. Kanucharan is trying to log in, and Dr. Venkata will log in too.
Okay, so Ritika is there. Ritika Hinduja is there.
Yes, I'm there.
Yes, Dr. Ritika. So how do you explain this graph? So the blue graph is rising and the gray graph is going down. So we are seeing the decrease in mortality of HCC. How do you explain this phenomena?
I think as you mentioned that, with the newer systemic agents, I think the mortality, which as you mentioned, the death sentence is now, they have some more survival to them. And that is why I think probably it is declining, the mortality. And plus, as compared to before, where we in India, at least we considered liver cancers to present, especially in the very late stage. Now we do see some early tumors which can be, treated with local therapies. So I think the incidence of early tumor detection and with better systemic therapies for advanced stages, I think that's the reason for the gap.
Yes, yes, you rightly said, Dr. Ritika, that the surveillance, our gastroenterologists and the hepatologists are putting this disease on surveillance. In chronic liver disease, there are many institutes who are getting a routine ultrasound AFP, and now they are moving towards a triple phase CT scan very routinely to pick up those lesions and early lesions. And we medical oncologists and we clinical oncologists will come late, but we have heard a beautiful talk from Dr. Ganeshan, an intervention radiologist, that these local therapies, the thermoablative therapies, the TACE, the TARE, the combination of TACE, TARE, the combination of SBRT and TARE, giving rise to that localized liver cancer, which can be treated early. And then when everything fails, when it becomes unresectable or metastatic, then we medical oncologists also have further options in first line, second line, and we have data on second line also. So we have all seen that our patients are moving beyond first line, second line. And this all scenario, this all combination of surveillance, localized disease, locally advanced disease, bridging that transplantation gap and further giving rise to systemic therapy has increased our survival. So Dr. Sudeep Banerjee, are you there?
Yes, I'm there.
So Dr.
Can you hear
Banerjee,
me?
so yes, so how is your practice changing? How your liver cancer patients are actually living longer, and how do you decide that resectable, unresectable, gross vascular invasion, extrahepatic vascular involvement in your practice?
Yeah, so first of all, with a referral center, so we tend to see both little early as well as advanced disease. And our workup, we routinely do MR liver, because we know that MR liver picks up some more disease in the contralateral liver, the future liver remnant, or maybe a satellite lesion or something like that with a big tumor. And also we do a chest CT scan. We don't do a bone scan unless the AFP is very high. There are data from Korea saying that if you do a proper CT scan with the thorax and abdomen, bone scan is usually not necessary. Now, what we have the treatment of HCC you see at present, if you talk about cure, there are only two treatments which can lead to cure. There are other treatments evolving. One is the resection, another is the transplant. Even if you see the smaller lesions, if you see there are recent data from Korea, if you see even if the smaller lesion, if you compare ablation with resection, the cancer specific death with resection is better. So cancer specific death is low with resection than the RFA, but definitely there are a lot of other things we need to consider. But now what we are doing now, whether first of all we see that whether this is upfront resectable or not, or upfront transplantable. If it is not, then we see that whether anything we can do to downgrade it to a resectable stage. For example, like adding some treatment like a TARE or a TACE or a combination of TARE or a microwave ablation, or some setting giving radiation to the portal vein. If there is a thrombus, maybe a V3, V4 type, mainly V3 type thrombus. So with the advent of multimodality treatment, few patients we are giving some upfront treatment and then resecting and hoping that the results are better. Having said so, also like over last many years in our centers also, the liver resection for HCC, the mortality is now close to 0%. We see the data, it is evolving slowly. When we are training, it is around 5 to 10%, 20 years back around 15 to 20%. But now for liver resection, properly selected patient, the mortality has come down to less than around 0 to 2% maximum in a properly selected patient. So the combination of therapy is definitely coming up when the patients are upfront, not resectable.
Very well said, sir. And you have beautifully summarized that our radiologists have made our life easy. Our intervention radiologists, the multiple local therapies in the form of thermoablative, RFA, microwave, and the combination of multiple TACE, SBRT or SBRT TARE has given that edge to the surgeons where they can resect, transplant, and you rightly said that even the branch portal vein should not be considered as a contraindication to liver transplant later. And very rightly said that surgeons have given that survival advantage where these resections and a bridge to the resection or bridge to the transplant is the way forward. So I here bring a case which very commonly seen in our Indian practice, and anybody in our panelist who can describe this PET CT scan so that I can take this case forward.
So may I take it?
Yes, sir, sure.
So this looks like if you see not the FDG scan, but the normal scan, this looks like a CLD, the irregular liver surface. And you can see a large lesion in the liver, as well as most likely a large lymph node in the porta or in somewhere. But I don't know whether HCC, such a avid HCC lesion, HCC usually low avidity, low FDG avid, but is an avid lesion in a chronic liver disease with a large node, what I feel.
Yeah, so this patient is no more. So this was a 35-year-old gentleman, hepatitis B related CLD, presented to oncology department with a huge liver lesion, and what looks like to a lymph node was a main portal vein thrombus sitting very separate from the liver lesion. And it was an unresectable disease. This patient is not a transplant candidate. So, and his child book B evaluation was score of 7, B7. So Dr. Amit Kumar, you are there as a medical oncologist here? Dr. Amit?
Yes, sir. Sure.
So Dr. Amit is here and Dr. Manas Saha is here, and we have radiation oncologist. Whose baby is this patient? How to proceed? The patient is B7, 35-year-old hepatitis B related CLD, big portal vein thrombus with a score of child book B7 and a good performance status of 1, I would say, walking to my OPD.
So the disease volume and the size, which say is too high and the portal vein involvement is too good. Might be it's the systemic therapy from my end will be the preferred first choice rather than going for SBRT.
What is bilirubin and
so it was child book B7. So there were two things abnormal. Bilirubin was normal. There was no ascites. INR was normal. Albumin was slightly low, 3.2 and less than 3.5, and there was no encephalopathy. The score becomes B7 or an early child book B, not A. This is not A.
So when he is walking to your clinic, yes, I think it's if we can treat, okay. So then this portal vein, I would like to go for SBRT for the portal vein, and if it recanalizes, then go for tear if they can afford.
Yes. So rightly
so
said.
what first is SBRT. So
yes.
We'll leave aside the previous discussion, whatever it is. So I think SBRT have a great role to play, especially if it is a portal vein thrombosis.
Yes. So it was
for
a
tumor, for big tumor, I definitely like to have my reservation, because SBRT I can use any other time later on if required. And if we have other therapies like local ablative or TACE or anything, I would like to use that first. In this case, a lot of radiation will take, this SBRT will take a lot of things for this portal vein thrombus. And portal vein thrombus, as it is said, that it will decide the fate. So first treat the portal vein and then go for the next line.
Yes. So we have an intervention radiologist on board as well. So Dr. Saha.
Yep, I am.
Yes. So Dr. Saha is saying that we would like to go for an SBRT, but sir, why not tear in this patient? Main portal vein is not a contraindication for tear. With tear, we can easily do, and patient affords it.
Yeah, really. But it is seen that tear, as such, even with tear, the portal vein thrombosis results are not great. If it's a tumor thrombus, it always better responds to SBRT than tear.
Yeah. So
and if you see now, they are doing huge numbers in Medanta, where they are seeing the great results, and they are doing it in combination tear plus SBRT.
Next slide, please.
And then medical therapy.
Yeah. So we have discussed, so the Dr. Saha and I believe my rest of the panelists also agrees that this patient should go for an SBRT. The response rate in literature, the many studies which I will come in next slide, the chances that this SBRT dissolve this portal vein is as high as 35 to 45%. And if this portal vein get dissolved and responds, it we have seen in our clinical practice that the child pug also increases, and it makes it eligible for another local therapy, which could be tear, and later on systemic therapy, and we can give. Coming on to a to a different scenario, an alcoholic liver disease, HPV, HCV negative, monitored by a gastroenterologist, you can say regularly or irregularly, abstaining from alcohol, alpha fetoprotein of 1900 microgram, and there are two liver lesions, one in segment 8 and one in segment 3, for 4 into 3 centimeter and 2 into 2 centimeter. My question is very straightforward to Dr. Banerjee. Is this operable? Would you like to operate first? You would like to give a local therapy first? And what decides what? Is this Milan? Is this beyond Milan? Or it is
it's a bit of beyond Milan, but I think this patient, 71-year-old, with a little bit of outside criteria for transplant as well, but with some sort, an AFP also quite high, 1900. But this patient, maybe a combination of, if the liver function is preserved, maybe a combination of pace with a microwave can be and observed for some time, and then can become a transplant candidate, not a resection candidate because of CLD.
Yes. So Dr. Tanuj, if you can chip in and tell us that as a GI oncologist, as a GI and a person who's looking at this HCC very quite often, what are those poor prognostic factors upfront which stops a surgeon to operate this operable tumor? If there are two tumors, patient is in child pug A, but what are those poor prognostic factors in a patient which should be considered on day one to decide these local therapies?
You mean the surgery that you're asking for?
So I'm just asking a general question. What are those poor prognostic hepatocellular cancer as a surgeon, as a intervention radiologist, or as a medical oncologist? What should we see upfront? What are those pathological factors? What are those secretory factors which decide, as Dr. Banerjee clearly was like saying that is alpha fetoprotein is high. So what is that volume of HCC in your knowledge? What is that amount of alpha fetoprotein which says that no surgery, this patient should go for a local therapy?
I would say not only biochemical marker, we have to look at the patient as a whole. What is the current performance status of the patient? Good thing is that he is viral negative. The bad things which, in addition to the performance status, we also have to look at the where the lesion is, whether it is close to the portal vein, how far is it from there. That's another criteria what surgeons will look into. Again, number of lesions, but here I can see there are two lesions, but one is 4 centimeter, which is little more than what the surgeon's criteria, the theoretical criteria mentioned in the books or the articles. Second thing is the AFP, Dr. Sudeep has already mentioned about it. And there is an autoimmune liver disease, which is it positive marker? The markers are negative. So again, autoimmune liver disease, if it's there, then again, that's again a negative prognostic marker. That's what
so I think yes, you rightly said performance status of the patient, child pug C, the Barcelona staging, how close is and what is that extra hepatic vascular involvement, the baseline alpha fetoprotein. But yes, the world is also moving towards. So we used to say that biopsy is not that essential, but in this immunotherapy and in the targeted era which is coming, the biopsy, the liver biopsy, the hepatocellular biopsy is very important. There are various prognostic criteria: lymphocytic rich, lymphocytic depleted, beta catenin positive, beta catenin negative, and there are various biomarkers, MSI, PDL1, tumor mutational burdens. So these biomarkers actually decide the way forward which patient will be treated, should be treated with lenvatinib, and which patient should be further treated with IO or bevacizumab. So I'm talking about systemic treatment, but yes, you rightly said there are prognostic criteria: alpha fetoprotein size, the volume of HCC, performance status, the Barcelona staging, the child pox status, they are all equally important. Next slide, please. So we have discussed, Dr. Banerjee has said, how do we evaluate resectability, and in unresectable patient, what are the most appropriate loco-regional therapy? I think I should move beyond. There's lots to discuss. Next slide. So historically, we all have seen, and Dr. Amit and Dr. Ritika and other medical oncologists are there. Ritika is a radiation oncologist. So we have seen that historical development of this HCC. We used to have sorafenib in our early days, 2007 to 2000, I would say 14, 15, when there was sorafenib. We were not able to give appropriate doses of sorafenib. Not many patients were tolerating beyond 400 BD or 400 OD. We have to de-escalate the dose. We have to decrease the dose because of hand-foot fatigue. Then came in our life was lenvatinib. So Dr. Amit, I want you to give 2 to 3 minutes on this lenvatinib, how this drug has made your life easy post sorafenib days. Dr. Amit.
Surely the side effect profile and efficacy wise, both lenvatinib is easier. The side effect with sorafenib, the hand-foot syndrome, is the most different, and hardly few patients tolerate 400 BD that cases. For lenvatinib, the weight-based dosing, whether 8 milligram or 12 milligram based on the weight, it is an easier drug to tolerate, and especially in the SCC patients somehow tolerate lenvatinib much better as compared to other malignancies, what we have seen. And though there are few conditions in which we are not using lenvatinib is not as effective, if there is a portal vein thrombosis or an arterial thrombosis is there, in those patients, lenvatinib is not a good choice. For sorafenib, it is similarly, if there is a hepatitis C infection, it is still a drug of choice, we'll say, if a patient is having SCC4 after that. So, or if there is an extra hepatic disease, lenvatinib is a good option in those cases, sorafenib is not, I will say. So, and the side effect, hypertension is the most common side effect we say with lenvatinib, which we is having other than the dry skin or diarrhea or other things. But still, it is a very easily tolerable drug, and we are so sorafenib is mostly out, I will say.
So where, yes, I was going to ask this very blunt question: when have you last written sorafenib in hepatocellular cancer?
So in recent years, no.
No. So in recent years, with all due respect to SHARP trial, sorafenib is out, lenvatinib is in, and if I go further to the NCCN guidelines, may I go next to the next slide? Next slide, please. Next slide. Please move on. Next slide. Next slide. Yes. So Amit, this is NCCN 2022. Atezo-bev is category 1, and in other recommended options, sorafenib and lenvatinib is also category 1. But somehow NCCN has given the preferred regimen tag to atezo-bev. However, sorafenib and lenvatinib are still in child-pug A category 1. And if I go to the next slide, 1 year back, the NCCNs, there was in preferred regime, all these 3 drugs are there: sorafenib, lenvatinib, and atezo-bev. So suddenly in 1 year, atezo-bev has become the preferred choice. However, sorafenib, lenvatinib are still holding the category 1. So somehow the clinicians, the pharmacology industry, and hepatologists, why there is inclination towards this atezo-bev? Amit, can you please explain what is that? I have given atezo, you have given atezo. Is it that effective drug in our Indian patients? Are all patients responding, and this NCCN preference holds true or not in your mind?
So it's not like that. Basically, atezo-bev, we have to do the endoscopy, rule out esophageal varices, chances of bleeding. Only if the patient is, so a definite subgroup of patient in which we are going to consider atezo and bev. And in Indian population, hardly patients go for more than 6 cycles. I will say most patients are going to progress in 7 to 8 months. Maximum, what I have seen, maximum number of patients. So for Indian scenario, I think so it's all equivalent. Might be the lenvatinib and sorafenib. It's the thing that it's a new drug and we have got a second line options much better. So for immunotherapy, they said that as early you use, it's the better response rather than in the second line when we have got a less response.
So Dr. Tanuj, your views on that. I want to, Amit has explained a bit of it. Dr. Tanuj, if you can throw some light beyond what Dr. Amit has said.
Yeah, NCCN guidelines, we all know how they work. It's difficult to say, we are in a different setup, we are in a different region of the world. Definitely the patients I have given Isobev, they have done really well. Lenvatinib works for a few months and then, as the trial has said, 2-3 months, and that's all. The side effect profile is good, but most of the patients are on lenvatinib at our center. Cost is a big issue for Isobev. It's a wonderful combination, but unfortunately, we do not have our patients taking up, a lot of patients taking up this option. Definitely, it is much better than lenvatinib and sorafenib. If the patients can take it, I would go for that.
Yes. So another factor which is clearly come up is the cost factor. That cost decide the cost of lenvatinib is actually nothing in view when it comes to Isobev, and we have so many generic molecules giving us lenvatinib and easily tolerable, pocket friendly, not even admission required, and can be monitored in OPD. But Dr. Tanuj, we have hepatitis B, we have hepatitis C related CLD, we have NASH, and we have alcoholic liver disease. Patient says, I can spend as much as my oncologist want. I want the best result. You have lenvatinib experience, you have Isobev experience. Will you differentiate? Will you differentiate according to the etiology of CLD? It comes in your mind, or it all depends upon the pocket, or it all depends upon any contraindication to Isobev or lenvatinib? Dr. Tanuj.
Definitely contraindications are there with Isobev. Uncontrolled.
I'm saying, sir, no contraindication. Both the patients can take lenvatinib and Isobev. Cost is not a factor. Is etiology a factor in deciding one of these drugs?
If the patient is treated with hepatitis B and C, I would go for Isobev.
Yes. Yes. So, and what is in your mind going in favor of Isobev?
The response trial, I am Brave 150.
Yes. Amit, you want to argue on this, or you any comments on Dr. Tanuj Chawla's statement?
No, it's okay. If the disease is controlled, both hepatitis B and C, it has to be controlled before starting Isobev. The reactivation is the thing which may happen. So I may go with the same.
Next slide. Next slide. Next slide, please. Next slide. Yes. So this is a Nature paper by Foster et al. And this is not very, it's a commentary to an editor, which has given a detailed research analysis that NASH, or an alcoholic liver disease, and they have also mentioned alcoholic liver disease, that NASH or non-hepatitis B or C related CLD limits anti-tumor surveillance in immunotherapy treated HCC. And what they have done is they have documented whatever evidence they have in literature that the amount of Treg cells, the amount of CD4 to CD8 ratio, the amount of inflammation which is required in a tumor, and the microenvironment of the tumor is lacking in NASH and alcoholic liver disease as compared to a liver disease, a chronic liver disease, which is hepatitis B or hepatitis C related CLD. So they have just, you can all go through this paper. They have just said that the Atizo or an immunotherapy response, the Himalaya, Durvalumab, or a Pembro-lenvatinib response will be higher if they have hypothesized this, will be higher if it is hepatitis B related CLD as compared to a NASH on an alcoholic liver disease. So viral and non-viral etiology related cirrhosis, we do not have a data, but if you see that Dr. Chawla was saying that if you see that I am brave subset analysis also, the hepatitis B and hepatitis C in the forest plot was slightly towards atezobev as compared to alcoholic and NASH. So this was a fundamental etiological. When we have three choices, sorafenib, lenvatinib, and atezo, are we wiser enough to choose one of them according to the etiology? There is no data behind it, but this is a concept which Nature has published 1 year back, and there is a research ongoing on this. Dr. Chawla, you agree with my this slide or not?
Yeah, no, I fully agree with you. And I wanted to add this point that when sorafenib trial was done, there was not much distinction, and patients who were viral positive, they fared poor as compared to non-viral positive. Subsequent to that,
Yes, sir.
Dr. Ankur, can I chip in just?
Yes, sir, please,
I'm
please,
the
please.
gastroenterologist moderator sitting here, Dr. Kingshuk Das from PGI in that way, old days.
Yes, sir.
I'm batchmate of Anjan Dhar. Anjan Dhar was a MAMC fellow ahead of you in that way. He was a gastro batchmate. My question is here. Now, can we buy microRNA? Can differentiate anyway that this is Hep B, Hep C related or the other group, alcohol, NASH related, or you apply more of AI? The time will come one day, maybe another 2 years, 3 years, 4 years down the line. By AI, we'll be able to differentiate this group of people. Who is going to develop what is CC and what is the etiology there, and getting a direction from there, we'll be able to hit the right place by your either Pembro or
Yes,
whatever
yes,
newer
sir.
things Nemo is coming.
Yes, sir. So yes, you are right. MicroRNAs and AI related, but a very simple answer to this is get a biopsy done.
Yeah.
Get a biopsy done if your INR, ascites, and there is no contraindication to biopsy. I am actually moving towards biopsy in hepatocellular. Give me a normal INR, give me no ascites. I would go a biopsy. And I was speaking to ILBS fellows, the pathologists there. Get something, tell me that this is an inflamed tumor.
But they say go for a liquid biopsy. Why to do for a biopsy directly? Go for a liquid biopsy and try to substitute that by that.
Sir. So circulating tumor DNA, the circulating RNA, and what is called as TMB, tumor mutational burden.
Yeah.
If you get this, so a liquid biopsy is easy to say, but still a good liquid biopsy platform fetches around 2.7 lakhs, 2.5 lakhs. And just imagine in our OPD setup, when we were struggling to get a lenvatinib dose, we were very happy to get a generic lenvatinib. Forget about, as Dr. Tanuj and Dr. Amit said, atezobev is disease and drugs of the richer people. So a liquid biopsy, it has to be standardized. It has to be available. People need to understand this liquid biopsy. And more important, we are sitting with our gastroenterologists, our radiation oncologists, our intervention radiologists, medical oncologists, surgical hepatologists, hepatic surgeons. They are also parallel department. So the big question is that liver cancer cannot be run by one department. It has to be run by many departments, but all the department has to come on board to decide a liquid biopsy, to decide taste, tear, SBRT. So there are many players in this disease. To get the best outcome, all the players have to talk and discuss this science and implement this science to a patient at a ground level. So this is a big thing. Yeah.
Yeah, can I say one thing?
Sir.
See, what is the problem with the biopsy earlier was in CLD patients, you are never sure how much it will bleed. So that was the main hesitation of doing biopsy in a CLD patient with HCC, because HCC is inherently a vascular disease. And that's why the result of TACE are better than any other IV chemotherapy. So now what do we do? In some patients, when we are forced, we still don't like to do biopsy because then we are asking for an intervention. Sometimes we have seen so many patients, even with 20 GLP needle, it bleeds. So what nowadays we are doing is a biopsy system is coaxial. We keep ready with the gel foam paste prepared. What we do is a coaxial system, do the biopsy, it will bleed. we wait for 1 or 2 minutes. If there is significant bleed is still coming from the tract, we just embolize with gel form and come out. So that's what giving a better way of doing biopsy, and we can now go ahead and do biopsy if required.
So I think we are running out of time, and you have raised a very, very important question. So time is up, but last question to my panelist, whoever wants to answer. What are the re-indications of biopsy in hepatocellular cancer? Dr. Saha, if you can,
only if you want to give immunotherapy.
So what I have seen is that the triple washout, the classical radiology, the classical AFP secretors are not always there. Not always there. Many times that scalloping effect, that when my PET scan or my radiologist clearly says that it looks like a mixed variety. When my CA 19.9 is bit high, alpha fetoprotein is low, I'm suspecting a mixed variety of cholangio and hepatocellular. AFP is not secreting, the patient liver functions are preserved. I want to fetch more out of it. So these are those patients I would like to get a biopsy done, explain the scenario. And many times, how many times you have seen that it was HCC to diagnose with without an alpha fetoprotein secretor, hepatitis B or C or NASH, but it turns out to be a cholangiocarcinoma or a mixed HCC and cholangiocarcinoma. So that changes our scenario. So we have to, as oncology is proceeding further, we have to pick up these patients also. Who will respond or not respond to IO is another question. But a right diagnosis for these patients is also required before actual treatment. Your statement, sir.
Sometime actually, sorry. Can I just comment one?
Yes, Dr. Banerjee, please, followed by Dr. Saha.
Yeah, there is something known as the bite and burn. So when you feel that this may be a HCC or it may not be HCC, needs a biopsy, but it is a small lesion, maybe a less than 2 centimeter lesion, then it is better to take a biopsy and do a microwave RF at the same setting. This is widely done in Singapore. I was working there in NUH. So this is something known as bite and burn. That is also one point I wanted to comment. Like whenever there is a doubt, but it is a treatable situation, you can combine these two things together.
Thank you, Dr. Saha. Your last comment, please, and then we'll conclude.
This was what I was actually coming to. So he just said that. So this is what we are now doing in some cases. If you need a biopsy, and if there is a small lesion which is treatable up to 3 to 5 centimeter, we can do a biopsy and do microwave or RF ablation in the same sitting.
Yeah. So at the outside, I will once again thank the chairperson, the organizers, and my panelists. I was just able to finish 25% of what was in my mind, but the time is the big speed breaker in our life. And thank you so much for being so patient and listening to me. And thank you so much again. Yeah.
So, Dr.
Thank you so much. Thank you, everyone.
Dr. Ankur, can I have a question?
Sure, Dr. Animesh.
So I would like to ask a practical question. So these HCC patients are often cirrhotic and they come up with a splenomegaly and thrombocytopenia. And when considering bevacizumab at a dose of 50 milligram per kg body weight, say patient having early varices, how would you consider proceeding? So do you prefer using romiplastim kind of stuff, boosting the platelet count, or do you wait? How do you proceed with low platelet count and bevacizumab 15 milligram per kg body weight?
So is this question for me, Dr. Animesh?
Yeah,
Yes.
any medical oncologist.
Yes. So in my practice, first of all, we have to see what is the reason, and most probably it is a chronic liver disease, portal hypertension giving rise to this thrombocytopenia. So my threshold is 80,000, and that was a threshold in I'm Brave. But yes, we have to seriously ligate them, do an endoscopic varicose ligation, treat them, ensure them that they are not bleeding, because the chronic liver disease and upper GI bleeding is common without bevacizumab also, and with bevacizumab my threshold is 70 to 80,000. If it is less than 70,000, I do not dare to give bevacizumab.
So do you recommend banding for early varices also, or advanced varices?
So 40% or 25% of the patient in I'm Brave had upfront esophageal varices, and it is a recommendation before starting bevacizumab, please get an upper GI endoscopy and get them ligated, get them sorted out, because that's an absolute contraindication for Bev. And the IMBRAVE 150 also has done that. So 25 to 40% of the patient had an upfront esophageal varices. That should be sorted out first before giving bevacizumab.
Another question, as you have already shown that NCCN guideline 2022. So all the recommendation, I mean, atezolizumab or lenvatinib are for Child-Pugh A. So the sorafenib is probably the only drug apart from nivolumab which are approved for Child-Pugh B. So the
Yeah.
case you are mentioning, Child-Pugh B7. So what would be your preferred option? Would you go with the recommendation, or would you tweak a bit and use the standard?
So in our what I say with double tag is our Indian practice. So I differentiate, and the literature has also differentiated early B and late B. If it is an early B, I go same as A, because we do not get, and our community and the presentation in our OPD does not allow so much of Child-Pugh A to come into our OPD. It's always B, what I would say. Child-Pugh C is out of question. Child-Pugh A we hardly get. And so I would like to differentiate with this B into an early B and a late B. If it is an early B, I would be happy with lenvatinib, and maybe with some local therapy with SBRT, if it opens up something, patient becomes better, so then maybe atezolizumab. But I've not been using atezolizumab, so sorafenib is a difficult drug. Sorafenib is a theoretical drug left, so I would rather be happy with lenvatinib with good monitoring of hypertension and proteinuria, because these patients have a big component of hepatorenal and other comorbidities.
Dr. Amit or Dr. Tanuj, any comments on this kind of child A, B, and selecting the treatment?
So completely agree with Dr. Ankush's comment. So we are taking early, the maximum patient we are getting is of B or C, hardly A we are getting. And for we are saying we are treating all the patients, so not C. Surely they are the best supportive care group. Might be some patient very keen on treatment, he may give, but it's not the treatment of choice. For B, early B, we are treating surely like this.
Yeah, for me, I would still keep a low threshold for atezolizumab for early B. I'll just see the overall picture of the patient. If he's generally well young patient, I may try atezolizumab even with early B.
Okay, thank you. I think we have to conclude the session. Thank you, Dr. Ankur Bal and all the panelists for joining us today. Thank you, our chairperson. Before we conclude this session, may I request Dr. Naziba to come over and hand over the memento to our chairpersons and panelist, Dr. Mano Shah, sir. Naziba, please. Nazib. Dr. Jibok. So we are at the end of our program. It has been an engaging and wonderful learning experience for me. I think the all of us was joining online or offline today will agree with me. Heartfelt thanks to all the faculties for taking time from their busy schedule and making this program a grand success. I'd like to thank all the delegates joining from different countries for taking their time to attend this program. And I'd like to thank the event management partner, Kavina Creations, Rahul, Kashish, Himangshi, who are working at the back end to over last 2-3 months to make this program successful. Thank to our audiovisual partner, TradeWings, for helping us with the audiovisual stuff. Thanks to our trade partner, Roche, and Zydus Oncology for sponsoring us for the CME. And thanks to our local organizing team, our hardworking PGTs, registrar, consultant for supporting us throughout this preparation. Thanks to our admin, respected DMS sir, CEO sir, medical superintendent sir, and everyone who has been involved in organizing this program. Without all of this support, it might not have been possible. Thank you all. With this, I would conclude this CME. Thank you and good night.